one immune reaction problem. They have multiple. And they may have allergies, they may have autoimmune disorders, they may have chronic inflammatory issues, chemical sensitivities, all of it. And it just tends to spread. So I'll talk to people about all of the different immune issues they seem to have, and they'll have some that they don't care too much about. Like, you know what, I have gluten sensitivity, I see like whatever, but I'm good at avoiding it, I don't really care. And I say, well, there's no reason you need to have that adverse reaction. And you may occasionally get exposed by accident, and it has the potential to light the fire anew for you, right? Also, it's very socially handicapping and limiting to not be allowed to eat, not be able to eat gluten in our modern world. Like once in a while, maybe you want to go out with your friends to a restaurant and eat restaurant food that's contaminated with gluten. And they always go, yeah, you're right. Like they've just sort of resigned themselves to their situation, and then it's difficult for them to believe that they don't have to live that way again. But other than that, I also explain, like, look, every one of these little fires we can put out for your immune system helps the whole fire go out. And that has been my experience. Like if people, we treat the major thing they care about, but we don't really deal with the allergies, there seems to be, and this is non-scientific, it's just my gestalt intuitive experience, it seems to be that they're more likely to rekindle their other immune problems. So we have to calm the whole immune system, try to restore normal, lack of inflammation in the body, and you get better, more lasting results until that other thing happens. So you can't say that you cure conditions with this just because they're immunological, right? Like you can cure testicular cancer because you can cut it off and throw it in the trash. Great. And then you're done because you no longer have a testicle. But in this case, you will have that same immune system. You can't just take someone's immune system out. They don't live very long. And so we're kind of stuck with this. It's great for job security. That's what I tell them. Because odds are you'll need me for a long time. Or somebody who does what I do or something related to it. But it is annoying. And it ties into that overall wellness picture. Like all of us are trained to kind of look at the whole picture, help people be as well as possible. And in today's world, with all the chemical toxins and things that people have been exposed to for multiple generations now, I don't think it's possible, it's kind of nihilistic, but I don't really think it's possible to achieve truly good health in the modern era now. It's my own example. My body quit making testosterone like it was supposed to. I quit making insulin like I was supposed to. I have to take DHEA, I have to take thyroid. I was born with such horrible eyesight that if I had been born in the wild, I would have been dead very quickly. Would have never survived. I had a -10 myopia. I could only see things that were this close. So I'm a product of modern civilization and all the ways that we have learned to overcome our particular handicaps. And that doesn't make me a healthy person. I look healthy on the outside. I'm a mess. and so when patients come in, they have these problems like, oh, I get it. Yeah, you do the best you can. You try to overcome the hurdles in front of you. And this is one way to help people do that. But it's so complicated that it's very hard to achieve, what we conceive of as like true wellness. Another really common question on here is LDI going to kill my parasites, kill the Lyme bacteria, the viruses? And again, that comes from our modern history since we developed microscopes and sort of the infection disease model. After developing penicillin and sulfur antibiotics and things, we started to realize, we can kill organisms and fix a lot of these things. And it's true that in the prior couple of centuries, a lot of people died of infectious disease. And so that was a massive improvement in health, and people stopped dying at an average of 40 years and started to go to 50, 60, 75 years of age for life expectancy, largely because of killing germs. So it makes sense that people societally want to cling to that belief pattern, want to cling to that strategy, right? But what I've discovered using this for all these microbial associated conditions is that there's another side to that coin. And like Dr. Raid talked about, maybe in some cases killing the organism works. Cool. If that's your predilection, try that first. If this is your predilection, you want to calm the immune response and try not to disturb their microflora with antimicrobials, try this first. But you may end up needing to switch to the other. So, stay flexible, stay open to other ideas. But it does demonstrate, like the success LDI has shown in the last 16 years at fixing, or at least, putting into remission, let's say, not curing, these microbial related chronic inflammatory illnesses tells us that there is an approach there. And there is a way to stop the inflammation and the immune response without killing the organism, because definitely the organism stays there. And you go back to living in harmony with your ecosystem. And if you think about it, if anybody's familiar with I had one friend in Alaska who adopted some kids, or a patient who adopted a few kids from Colombia that had basically been feral children living in the jungle of Colombia, and they came to the States and they all had multiple intestinal parasites, things that we in the United States consider pathogenic parasites. And these kids had no gut symptoms at all. They're fine. So, and a good example of that also is people who go to India, like the people living in India are cool with their microflora and their ecosystem, but if a American or a Canadian goes to India, many of them get extremely ill just because you're going to pick up the regional flora. And they're protozoa. I don't necessarily like the word parasite for all of this because that's really a negative thing. It's like they're co-inhabitants of your gut flora, right? And we call it a parasite when it makes you sick, but somebody else carries it and it's just normal flora. So to me, the difference, right? Like, what is the difference between the sick person and the well person when this variable is the same? If the presence of the organism is the same in both groups, there's another mechanism behind the illness. And to me, it, in many cases at least, is how the immune system reacts. And if you didn't grow up in the presence of those organisms, you have no familiarity. You have not developed tolerance because your immune system hasn't seen it and chosen to consider it as normal. And then you get exposed when you have a mature immune system, and maybe you're in a position in your life where you have some level of immune discontent and inflammation, and then you get exposed to this new thing and your immune system freaks out. I will tell a story in that regard that's also ties into autologous LDI and whatnot. I think this is a really great case study. And it was another physician, colleague and friend of mine from the AEM, who I'd known for years. Older man, I think when we started treating him, he was about 80, or maybe late 70s, because it's been a while now. I think my wife was pregnant with our daughter, so probably 7-8 years ago, actually. Excuse me. And he had gone on a trip to Peru, Vision Quest or just holiday, I don't know. And he went down there, and while he was there, of course, he acquired some passenger in his gut, and he got incredibly ill. And he started having his diarrhea as he was leaving Peru, but he had to stop at whatever state or place he ended up on his first flight, and he had to leave the airport, change his plans, and go to a hospital because he was having just watery diarrhea every 30 minutes. And he spent days in a hospital. I think he was still in Central or South America at first, and they gave him all the antiparasitics they had available and antibiotics they had available for what they suspected he may have picked up, because it definitely seemed like an intestinal parasite, and they didn't work. And he kept having to be in the hospital and stay on hydration, and nothing would stay in him. It was just going through him. And he eventually made it back to the United States and was in his hometown in Idaho, I believe. And he emails me, and I have a copy of the email because it was pretty short. But he tells me stories like, Ty, I picked this thing up and I am dying. It's like nothing has worked, and I'm having watery diarrhea constantly, and I have to be on IV fluids, and I feel like I'm dying. And he's, 78, 80-year-old guy. You can't really handle that very much. And so he says something like, I think you might be the only person that can help me. And I'm like, I don't need that kind of pressure, but I will certainly give it my best shot. And so I was like, well, all right, the story said parasite mixture, and I have a parasite mixture. Those of you who will access this, you'll get it and you'll use it. You have to know it's very limited. And that's because these things aren't widely available. Even the person that I had, Leo, who had the warehouse in Orange County, he didn't have every protozoan and worm in the world. He had about a dozen of each. So the parasite mixture has a dozen different types of protozoa, and they're all listed in the LDI formulas manual for you, and a dozen different worms, including rope worm, which is actually debatable whether it's really a worm or if it's just a bunch of mucus, but whatever, it's in there too. So I gave him that, sent him that, he titrated through, and it had no effect at all. And so I was like, all right, the next thing, I'm not gonna spray him with all this other stuff. I said, just send me a sample of your stool, because I'm gonna go to autologous. Like, whatever you picked up is some exotic Peruvian protozoan, perhaps. It's hard in the alliteration. And then he goes, okay, I'll send you my stool, and it's, of course, liquidy stuff he sends. I happened to be out of town at the time it arrived. I was speaking at a conference in Las Vegas, I think. So my wonderful wife, Jeanette, who's 7 months pregnant, and they're all a little nauseous, queasy. They don't have a strong stomach necessarily to begin with. People for dealing with somebody else's poop in a cup and having to dilute it. For some reason, I can do that without batting an eye, but most people can't. And even after it exploded in my face, I didn't throw up that one time. So she tried like hell to make his dilution, and she tried and drew some up, and then she started retching and peed herself, and took a shower. I was like, all right, this guy really needs our help. He's gonna die. And she tried again, and she got new clothes on and everything, and then tried again and put a mask on with essential oils and everything, and then it happened again, and she could not do it. And she calls me And I'm laughing. She told me the story, and she's like, "It's gonna have to wait till you get home. I can't save him. He's gonna die." you know. Luckily, I got home a day or two later, and I made the autologous dilution, and we sent it to him. And I'm pretty sure I started him at 6C, because I start most people at 6C with an autologous dilution. If it's a new antigen in general that I'm playing with, I usually start things at 6C, because that's been the majority of antigens. It's a good starting point. It's safe, except for things like Lyme and yeast that have this broader reaction point, right? So I set him 0.5C increments, and when he got to around 4C, he started to have a serious reduction in his symptoms. Maybe it was 4.54, and I think that because we settled at 3.5. So after a few doses, he's getting better and better, longer and longer, and eventually we just kind of gradually titrated in. I think he gets like 3.5C, 5 units or something like that, and his diarrhea just stopped. And he fully recovered his health. And then we realized he also has food sensitivities and whatnot. And again, like if you have this parasite reaction in your gut that could be rekindled at any time, and you have food allergies, and you might occasionally eat the food allergen, it may cause gut inflammation to start again and then flow right back into that other reaction pattern, right? It's right there. So I was like, we really better treat your food allergies. And he wasn't even that interested at first. He's like, we really should do this. And so we eventually dialed in the food mixture too, and found where he was able to figure out what he was reacting to and do test exposures. And so eventually we got that dialed in too. And so for like the last 4 years, he's just been on the same doses. His health is great. He's in his mid 80s. He and his wife moved to Costa Rica. They do come back and forth to the States, but we just, still in contact. He still gets his doses. We send him a few cycles at a time. And it was amazing. And I honestly don't know what else would have worked. Right? I mean, there's other things that might. Maybe there's other antimicrobial things you could do to kill this off or something, but I don't know, and I'm just really lucky that this worked. And I like to tell that story because it's something that a lot of you may run into. I had a nurse at my clinic had a very similar experience, but luckily when he got back from Peru, his gut symptoms eventually calmed down and went away. We didn't have to do anything creative with it. But it's an instructional story, I think, because it was an autologous case, which I always find fascinating, because we still don't know what the organism was that he reacted to. But the beauty of it is you don't have to know that. You can just get it, whatever it is. And that's when the first time I lectured about this at all nationally was 2009, talking about autologous LDA, I called it then, and using it for inflammatory bowel cases, and it was just miraculously effective. And I thought, this is really cool. Everybody needs to know about this. And then I talked about it, and everybody came up after, was like, wow, I can't believe you did that. That's amazing. I'm like, yeah, you should try it. Let me know, if it works. And to my knowledge, like, no one bothered to do it right away. Dr. Schrader took an interest, and he did start playing with it and would tell me, oh, yeah, this is cool. This works. And then he started incorporating that into teaching LDA, which I think is great. And I know other people I've talked to said, no, I did try that for a while afterwards. What I discovered was maybe people were trying it and they just weren't communicating back. And so what I want to implore all of you to do is please communicate back. If you come up with something, if you have an experience that is new, that other people could benefit from, I would like to know so I can pass that on. I have a limited patient population myself. I see maybe 10, 12 new people a week. That's it. Some of you are going to see 10 new people a day at times. So the collective information we can gather is far greater than my personal experience, and that's much more important. Somebody asked, how do you sterilize the solution again? So you use what's called a millipore filter. And I think maybe the table we have a lot of provider tools and information. There's a table for dilutions, and we have a video I know about how to make autologous LDI that if you can't find it in our YouTube catalog, then Jeanette can tell you exactly which one it is or send it to you, and it will show you how to go through the whole process. But if you imagine my coffee cup has a bunch of poop in it. It is brown, but you draw your sample out of there, whatever it happens to be. You want it to be thin and just primarily liquid. So like I talked about the poop explosion story I experienced, there were too much stuff, material, solid things in there. So I learned that I better dilute that more before I draw the liquid out, and then I can pass it through a filter. Millipore filters, you want to get the ones that have a 0.22 micron pore size, which is very small. It will accommodate red blood cells, but it will not accommodate bacteria. They're larger. So you want to get one of those. You want to get the ones that are about 44, 45 millimeters in diameter, because it'll hold some reservoir, some flow. It'll hold some of the particulates and allow you to filter more easily, but it will also capture maybe half a cc of the volume. So you would draw out like at least 5 to 10 cc's of your solution and hope that it's pretty thin, and then put the filter on the syringe, and then put a needle on the filter, and you pass it through, and it will filter through, and whatever comes out into the vial. So you're going to inject it into a sterile, empty vial. Okay. Sorry, I don't have visual aids and use my hands a lot. You inject it into the sterile, empty vial, and whatever comes through is considered sterile. That being because the pores are too small for bacteria or protozoa or living creatures to pass through. I would contend that viruses can probably still go through just fine, but it's viruses that patient already has, and I don't think there's any potential for harm with that. I don't tend to use people's autologous solutions for other folks, except for the HGM mixture I put together, which I think we talked about yesterday. The human gut microbiome mixture is from 90 or so different people's autologous samples. And it's conceivable that there are virus particles in there that might be, transmissible. However, I made that a couple of years ago, and it's just been sitting in water, and so if there were virus particles in there, my guess is they're inert at this point. They don't live forever in just plain water. They need cells to live in and to replicate themselves, and so I don't think viruses are going to persist in that water, not for more than a month or something, but definitely not years. So I think it's probably safe and fine. I use it for patients, but if you do think you want to make any custom solutions, dilutions of your own, you will have to get some millipore filters. And you may want to, partner with some of your colleagues and just go chip in together and buy a box, because they come in boxes of 100. Maybe you can find boxes with smaller amounts, but when I've found them, it's always been 100 at a time. And you're not going to use 100 of these things in a decade, probably, unless you're doing a lot of cool creative stuff. So that's one of the supplies you might need. You're going to need syringes. You can put Luer locks on, your 10 cc syringes for big things like this. You're going to need insulin syringes to do the doses themselves, and we recommend the 30 unit syringes because the markings are further apart and you can be more precise with the dose that you're giving. Don't use a 100 unit insulin syringe. They go in twos. The lines are actually 2 units at a time. Don't use the 50s if you can help it, but the 50s are okay. It's the 30 unit syringes where you have better precision. And like Dr. Raid was talking about, and I've talked about, 1 unit makes a difference for people. So, the more precise you can be, the better, honestly. And then the other question I get a lot here, and these all kind of relate to treating for microorganisms, is this going to leave me defenseless, basically? Like if you treat me for the Lyme bacteria, does that mean that the Lyme bacteria are going to run rampant and they're going to kill me? And at the beginning, when I was learning about Lyme disease and managing this with people, and the whole theory of the case is that it's an infection, that the organism itself is causing damage. And there's all kinds of interesting fairy tales about it burrows through your skin and burrows into this, and it turns into cysts that evade antibiotics, and it mutates all the time. And those beliefs, those stories come from observations about how hard it is to treat this thing. And then people make observations and they come up with an explanation that is not scientific and is not proven, but it's the working explanation until somebody can disprove it. Basically, think Greek mythology. The sun goes through the sky, that must be Apollo with his chariot burning horses. That makes total sense. Sure. We don't have telescopes and nobody questions it, so that's the prevailing view for a long time until you get a telescope. Or until Copernicus comes along or something and says, it doesn't make sense. So when I started thinking about this, and I developed enough confidence in my theory of the case that I don't think this is really an infection. Other people have the organisms and aren't sick. So that to me says the organism itself is not sufficient to cause illness, let's say. And I thought, it makes sense to me, let's give it a shot. And that's probably been my attitude all along. If I think about it long enough and it makes enough sense to me, I'll give it a try. And so when I put this together and I gave it a try, I was really pleased to see that it worked well. And I never had anybody just kind of suddenly start getting overwhelmed by infections and things like that. And so I decided Borrelia is not an infectious organism. We could debate that all day long. But Candida is definitely a potentially infectious organism. We know that. Like people who get immune compromised, they will get Candida out every orifice, okay? Skin folds, esophagitis, just terrible. And we know that. So people who are on immunosuppressive therapy or who have AIDS, they end up on fluconazole or some other antifungal constantly, because we know that being defenseless against Candida is an absolute potential death sentence, okay? But we do not see that with Borrelia. We do not see that with Bartonella. We do not see that with Babesia. We do not see that with most things, right? Your body is carrying thousands of different microorganisms. The vast majority of them are essentially inert to us until they get in your bladder or your airway or your bloodstream or someplace they do not belong that's supposed to be a sterile compartment. And then that is the true definition of an infection, right? Everyone out there listening has E. coli in their body, but you do not have an E. coli infection. Unless it's one of those weird strains you pick up from another country, traveler's diarrhea. The people who live there are fine with it because they've lived with it and they have immune tolerance. You get it and you get this variant of what is it, immunotoxigenic or whatever, E. coli, and then you get diarrhea. So perhaps we could use our UTI mixture that contains E. coli and stop traveler's diarrhea. Or take it before you go, and maybe you won't get traveler's diarrhea. Maybe you take the parasite mixture before you go to India, maybe you won't get deli belly, or whatever you want to call it over there, right? And so those are things to consider and think about, right? If you understand the logic and the way to think about this, which is really my impetus, is to just make people think differently about things, you can be creative, you can be safely creative, you can come up with strategies that solve problems that haven't previously been solved. And that's just what I want to impress upon everybody. So the Candida thing, back to that, is absolutely a pathogenic organism you must have adequate defense against. And I've treated people for yeast sensitivity with the Candida mixture since 2009. I have never seen a person start developing Candida overgrowth and infection through the use of that. It's just not a thing. So that's why I go back to my division of the immune system functionally into tolerance versus defense. And we are only manipulating the tolerance side of that line, and defense is left completely untouched. And I feel confident about that, mainly because the Candida example. I think it's very instructional. How are you sterilizing? Okay, somebody asked that again. All right, let me see if there's more slides worth talking about here. Managing allergies. Okay, so there's a difference, and I've alluded to this, or mentioned this before. Like when you're dealing with allergies, you're dealing with something you could potentially test. That is a huge difference from internal microorganism LDI, with one potential exception being maybe yeast. So I will see people who have yeast sensitivity and they tell me I can't eat anything with sugar. Like if I have anything with sugar, even like if I eat one grape, I might be okay, but if I eat 3 grapes, I'm not okay. And they're very aware of this, and they have to be low sugar diet. So you could potentially, in some of these cases it works very well actually, give them your yeast LDI dose, and then about a week later, have some sugar. And that is a valid and very useful test exposure for people if they report that phenomenon. You'll get some people who say, nah, I think I tolerate sugar fine, but then when you ask them, they're eating a lot of sugar every day. And so they really don't even know, because they don't have a comparison, one day without sugar, one day with. So in those people, like, well, just take the doses and you're going to passively observe for improvements in symptoms or changes in symptoms over the following week. And that's all you've got with internal microbes most of the time. But with allergies, you have the potential to be more scientific and more objective with what you're doing. And so you want to ask them, what are the things you know you react to? Give me a list. And how do you react to them? So I don't accept people just saying, I'm allergic to carrots and chicken and beef and shellfish and blah, blah. I'm like, okay, one at a time, and you tell me what symptoms you get from each one. And if they tell you it's all the same, they'll give you like 50 things and it's all the same reaction, those are not food allergies. They're reacting to some other process through eating and digesting. Maybe they're feeding certain gut organisms, and then the gut organisms are the antigen. It reaches a threshold effect, and that's why they set off. Or they're reacting to chemicals that are within most American and Canadian foods these days. So you might try the chemical mixture. Or maybe they react to yeast, and everything they put on their list has a lot of carb content in it. Like, okay, well, you might be a yeast reactor. So there's just different ways to think about that, and I want you to just conceptually go through that with people. But if they do say, oh yeah, chicken gives me like a horrible stomach ache and nausea for 2 hours, and eggs give me eczema in my elbows, different reactions with different foods, and they happen consistently the same way every time, that's the information you want, and that is extremely useful. Then, when you're going to choose where to start with the food mixture dilution, and the same thing applies to like environmental. If people say, oh, I react to mold like this, I react to cats like this, I react to dust like this, grass like this. In any of these cases, you want to identify what the worst reaction they have is. So let's say with foods, they go, oh yeah, corn and chicken and beef, they give me a diarrhea and a stomach ache. But if I have shrimp, I'll have anaphylaxis. I'll get hives, I'll get throat swelling. Like, okay, well then the shrimp is the one we need to focus on with testing first. And that's because that dictates or necessitates starting at a weaker dilution than the others would. So if you were to ignore that outlier and let's say, oh, let's just start you at food 6C, because that's where these other reactions are all pretty mundane, let's start you there, but they need the shellfish mixture at like 8C, you might get success with all these other reactions, but if they ever get exposed to incidentally or they try to test their shellfish reaction, it will be worse. And that's very dangerous potentially. So you want to start with the worst one. And it's counterintuitive to the patient. You'll have to explain this to them. Like, well, I don't want to eat that. I go, blah, blah, blah. Like, it's dangerous. I'm like, that's exactly why we have to fix it first. So if you focus on that, the worst one, the one that has potential anaphylaxis, hives, whatever, however you determine that it's the worst, use that as their test exposure, and maybe you find the whole food mixture, you get to like 8C, and the shellfish reaction just stops. And then you go, okay, what about all your other reactions? In a lot of these cases, they'll say, oh, my other reactions went away too. Yay, that's great. But in some cases, they'll say, no, I'm still reacting to eggs, I'm still reacting to dairy, corn, whatever. Then what you have to do is you have to give them all those submixtures individually. You cannot proceed with the whole food mixture because you know you will overdose them for their shellfish reaction, and that's not safe. So these are complicated cases, and it's super annoying because you'll end up having to break these out. Okay, what are all the things you react to? And then they might need the dairy, the egg, the corn, the nightshade mixture. And you know, it's just extra work and it's extra documentation, but you can dial this in for people. And you will find these really complicated doses in my patient records, but that's just where they are. That's what they need. And most people will have a fairly homogeneous response pattern where all of the subgroup reactions respond at the same dilution. That's most often the case. But you will see people where it is diversified. And you better just be aware of that. And I want you to start focusing on the one that's the worst, because that's the one that can get you into trouble. So start there, titrate through. When that reaction goes away, assess whether any other reactions are continuing, and then target them with these submixtures, because you do not want to overdose them with the one that is the most dangerous. So I hope that makes sense to everybody. And then you do your testing about 6 or 7 days after the dose. Try to tell them to do all of their test exposures by day 10. Some people are kind of annoying about this because they'll be like, oh, I'm just testing one new thing per day and I have 8 things I want to test. Like, well, then that's going to take too long. And by the time you test thing 8, it's been 2 weeks, and now maybe the dose wore off and you're reacting to everything again. You still get pretty good information. So if they want to do it that way, whatever. They'll be like, no, all these reactions went away, and then I tested this other one on day 14 and I did have a reaction. Like, okay, well, let's just move the whole thing 0.5C stronger. And generally that is fine. You can get away with that. But if they'll do their testing in that short time frame, you get better information. And it's hard to make good decisions with bad information or no information, particularly with misinformation. So you really also want to pin your patients down on what they're saying. When they use words, what do those words mean to you? Because like my family is so sick of hearing me say, words are the tools that we use to convey thoughts, ideas, and emotions from one brain to another, but it only works if we agree on the meaning. And I just do emails with people all the time, so this is really common, and I'll have to go back like, what do you mean by this? I can interpret it this way, this way, this way. And they're like, oh, no, I meant this way. I'm like, thank you, and then we can proceed. But I'm very careful about words and communication because misunderstanding people can lead to bad outcomes. So you're going to just titrate stronger till the dose or the reactions begin to go away. If it lasts a month or more, repeat the dose, maybe adjust the volume. These are things that we've gone through repeatedly. They're also in the provider manual and videos. So I try not to belabor all this point here. Had LDI worked well is for iodine allergy. So I actually don't believe iodine allergy is a thing. But if you do see some, and I say that because the only times I've had people mention that they had iodine allergy were they had shellfish and somebody said, oh, it's because you're allergic to iodine. And I'm like, I have no idea where they came up with that theory, because it's actually tropomyosin. It's a muscle protein in the shellfish you react to. That's the epitope. It is not iodine. And I don't know why iodine would be the suspect there. And then I'll say, well, can you eat seaweed? Like, can you have sushi with kelp and whatnot? Like, oh yeah, I can eat that all the time. Then you're definitely not allergic to iodine, because there's a hell of a lot more iodine in that than there is in shellfish. And the other instance is where they will say they got some kind of medical substance that has iodine in it, and they reacted either intravenous dye for a CAT scan or the betadine or something you paint on the skin. And they're like, oh, I reacted to that, so they said I'm allergic to iodine. Iodine is one atom element in that large molecule. The rest of it is foreign. molecule, and I don't know why iodine is the thing that's implicated as the offensive antigen or epitope. But I have not yet seen a person where, they have that story, and if you say, here's a drop of Lugol's iodine, and you put it on the skin, nothing happens, you put it in the mouth, nothing happens. I have not yet seen a patient who truly has reacted to iodine directly. But if you do, and you better test it with pure iodine, like Lugol's or something like that, if they do have a distinct reaction to that, one, I don't know how they're surviving, their thyroid should have exploded by now, but just dilute the Lugol's, right? So you take whatever they reacted to, and you could do this with betadine, but I would expect the chemical mixture to probably resolve the betadine reaction. The CAT scan dye, the problem with that is nobody's going to go in every week and get a CAT scan or asked to be injected with the dye just to see if the treatment worked, right? So logistically it's problematic. But just take the thing, the iodine, and we can get this in basically elemental form. Lugol's has potassium in there too with some of it, but it's primarily iodine. And then dilute it out and find the place that it works, and that should be fine. That should work. But if anybody does find a case where you can legitimately prove that they reacted to Lugol's iodine or some pure iodine form, I'd love to know, because to date I've not heard of that. So you got to, think about what are all the possible things that somebody could be reacting to specifically in a story like that. We make a lot of assumptions. I think, this is it. Patients make assumptions all the time that any new problem that they incur while they're doing the new therapy must have been caused by the new therapy. And that's never the case with LDI. I can very, very confidently tell everyone, you cannot cause a new problem with LDI. I have given tens of thousands, probably 100,000 or more of doses to people over the last 15 years. I've never seen somebody develop some new problem because I was giving them the Lyme LDI and now they develop like Lyme disease problem that they never had before, for example, or some new symptom they didn't have before. It just doesn't happen. And it took me years to gain confidence enough to say that after taking every reaction seriously, waiting 7 weeks, titrating back. It takes a long time to work through this and feel like you know what's going on. But I've never had a case where I could validate that the LDI had truly caused a new problem. There's always another explanation for it. And people live in the world with 1,000 variables they're exposed to every day. What you ate, how you slept last night, where you went, the chemical exposures, the weather, the barometric pressure, how your conversation with your partner you had that day, whatever, your stress level. They all affect these health factors. So whenever somebody says, I took my LDI dose and then the next day I developed this or that problem, I go back to their note and I'm like, well, those aren't symptoms you told me about before, so those are new, and there's no way it's related. What you need to do is evaluate the chronic symptoms you've had and let me know if those have changed over the course of the week, or do your test exposures for the foods over the course of the week and let me know how that went. Try to stick to the information you have that you feel is the most trustworthy, okay? And don't necessarily believe what they want to believe that the new problem was caused by the new therapy. It's usually not the case, and with LDI it's definitely not the case. If a patient's also being treated by an allergist with allergy shots, guess they have to stop the shots. So I mentioned this, I think, yesterday, but it depends on if you want to use the same antigens or overlapping antigens. So if they're going to the allergist and getting shots, that's primarily environmental inhalant allergens, and it's whatever they decided to test the person for. So let's say that they're being treated for cats, dogs, mold, grass. You couldn't give them the environmental mixture, or you wouldn't want to, because you're duplicating therapy. One's going to affect the immune system in one way and the other is going to affect the immune system in a different way. And we really don't know how those are going to sum up, if they're going to be like synergistic, problematic, if one is going to shift the dose requirement for the other. It's just messy at a minimum. And so I try to avoid doing that. If it's a different antigen, go right ahead. I mean, if they're getting allergy shots for inhalant allergens and then you want to treat them for foods or for Lyme disease or yeast or whatever, there's absolutely no problem whatsoever, because you're not trying to ride a bike and a skateboard at the same time in that case, which you could try to do. But it's just probably not a good idea, because then let's say you do it and you find a successful combination therapy. You stay on these allergy shots and you take this LDI dose and then everything's covered. That's just unnecessarily complicated. Then they have to keep doing 2 therapies, going to the allergist's office, getting the shots, and getting your LDI doses, when it's extremely likely that the LDI would work all by itself. If you just gave them 1 dose of the environmental, it would probably cover the things that are in their allergy shots and the other things that weren't being covered by their allergy shots. So what I tell people is, if you're happy with your allergy shots and they're working well, you can continue those and we'll just treat you for the other stuff. But if you get tired of driving 2 hours to your allergist's office every week to get your shots, and you want to look for an alternative approach, then you'll just have to stop doing the allergy shots, and you will have to wait until your allergy symptoms return, and then we can implement our environmental mixture. But you won't be able to do it until they are symptomatic again. And that goes back into other symptomatic therapies where people are having good success, whether they're on an immunosuppressant therapy like Humira or Enbrel, or whether they're on an antihistamine and Flonase and Singulair, things like that to control their allergies. If they're on something that has truly controlled their symptoms, you have no way of determining whether LDI is going to work or not unless you have a laboratory marker. So there are instances of that. I've had one person, friend, colleague, again, actually a physician, who was diagnosed with a type of inflammatory bowel disease, but went on Humira, I'm pretty sure it was Humira, and controls the symptoms. However, he'll do stool testing and his fecal calprotectin level is still like 90, 100, like running high consistently. And so in that instance, like, hey, we can go ahead and try it because we have this biomarker. We don't have to go by symptoms. And so we take one of the yeast LDI doses, I think in this case, or you could end up using the GI bacteria or foods or mycobacteria, whatever. But you try that, and then you just have to check the fecal calprotectin level every 10 to 14 days later. And if it's still high, try the next dose. Repeat, try the next dose. And eventually, if you're lucky and if it works, you get to a point where, oh, your calprotectin level dropped all the way to 20. Like, it's fine. And then they can feel comfortable coming off their immunosuppressive drug, right? And you just maintain that therapy. So you could potentially do that. But if the person does not have a laboratory marker to use as a guide for success or failure, you will just have to tell them, we have no way of knowing if a dose works for you while you're asymptomatic. The only thing we could do is go through the dilutions until we flare you. And then nobody's happy, and we may create a situation where your Humira doesn't work anymore because now we've worsened your baseline situation. It's not safe to do that. So I just tell them, look, just get off the immunotherapy. Uh-oh, I think I lost him. Yep, we're rebooting. I think that was the only time that happened today.
Recording in progress.
Back to the process. Okay, I think we're back. Sorry everybody that Zoom dropped us again, but that's not bad. I think that's only been maybe twice today. I thought I did it once to Dr. Raid, so. Okay, where I was at with that, you're going to have to just withdraw their symptomatic control or their immunosuppression therapy until they have symptoms that you can track, and then implement your antigens and go through the process. And I've had people that have really, really severe autoimmune problems that do not want to risk that, which is fine. I said, if you get to a point in your life, in your mindset, where you don't want to take the immunosuppressant drug anymore because of the risk of developing lymphoma or life-threatening infections or what have you, we can do the transition whenever you like. But you have to explain to them this is the situation. Or if you get to a point where your immunosuppression isn't working adequately anymore, because that happens too. It starts to fail for people over time. Like, now I'm getting symptoms again. They're only about half as bad as they were without the TNF inhibitor, so I'm staying on it. I'm like, great, as long as you have symptoms that we are pretty sure are related to the problem, we can treat you. When the symptoms are resolved with a dose, then you can withdraw the immunosuppression or stop your antihistamines or whatever. If somebody's on antihistamines, nasal steroids, things like that for environmental allergies, what I do with them, because what you want to ask them is, if you stop your drugs, when do you start to see your allergies return? And you want to write that down so that you can structure your advice around it. Some people will say, oh yeah, if I don't take it, I have bad allergies by that afternoon. Okay, great, that's easy. Or, my allergies will be back by a day or two later. So what you're going to do is go ahead and give them their LDI dose for those allergies, and then tell them, 4 days later, stop taking your antihistamines, if they have a 2-day delay. And if they say, oh yeah, the same day I'll notice, then just go on day 6 or 7, just stop your antihistamines and such, and see if your allergies come back. And then you'll know. It's that simple. You don't have to tell them to stop all their things that they've come to rely on and make them feel safe and secure, because you have a way of figuring this out. You just have to decide, how am I going to know if my dose works or not, and puzzle through that. So this is an example of non-homogeneous responses, I say, like with one of the complex allergy mixtures or with the Lyme mixture, this can happen. And it's really just those things that I have as a collective of subgroups. So some patients will require different dilutions for different allergens, and I mentioned this a minute ago. These are some examples, and sometimes it gets even more complicated because they need larger volumes of some of them than others. So I have patient records where they've got 5 antigens and they're all at different dilutions, and some are at variable volumes, and that's just been months or years of making fine-tuning adjustments until everything's under control. And it's tedious in some way, but it's worth the effort because then they're fully controlled and you don't have this persistent inflammatory response to contend with those people. But what you want to do, like I talked about with the shellfish and the other food allergy example, is titrate with the whole mixture first. And when something resolves, take note of whether everything has resolved or not. If people don't have severe reactions, like for foods, for example, they'll be like, they're all kind of moderate, not life-threatening, just mostly annoying kind of symptoms from their foods. What I've discovered is if one of their allergies goes away and the other ones don't, I'll just keep moving the whole mixture and say, okay, well, let's just see. What I found is that certain allergies will seem to respond just as well over a span of like 2 or 3C, which is interesting. So like, oh, I quit reacting to eggs, but I'm still reacting to wheat and carrots or chicken or whatever. Like, well, let's just move the whole mixture stronger and see 0.5 C at a time. At that point, go 0.5 C at a time. And you may go, oh, 0.5 C, another couple of allergies dropped off the list, but there's still a couple hanging on. Oh, let's go to, 1 C stronger than where we were, right? From 6C to 5.5 to 5. And you may get to 5 or 4.5 C and all of their allergies go away with a single dose. And it's worth trying that first because this thing on the screen is complicated and annoying. So if you can get a homogeneous response with the whole mixture, I encourage you to do that. It's easier. And it used to be that I didn't have the confidence and I would just stop and go, okay, let's break out the submixtures then. And then I realized that there is some flexibility, and some people, their allergies will respond just as well over a range of dilution. It's not precise. And that's just a difference person to person. So I always, unless there's a severe life-threatening reaction I'm dealing with, as soon as that goes away, I don't mess with it. I'll just leave that where it is and then move to other subgroups. That's been very rare so far, but it may happen. In most cases, the allergies aren't that huge of a deal. They're not life-threatening. And you can, have the confidence to move the whole mixture, the whole composite mixture stronger, and hope that you can have a unified dose that works for everything, because that's a lot easier. It's a lot less work. You'll find that, drawing up doses, and the more your LDI patient load builds up, the more you will seek a technician who actually makes the doses. Because I made all these myself for a while, for years, and then pretty soon everybody hears about it. Everyone's coming in with this or that problem. I'm being creative. I'm like, hey, let's try this, let's try that. And I'm making more antigens. And then after a while, you're like, I got to train somebody else how to do this part. Because it's not something that requires thinking. Once it's in the record what you want to give, somebody with just good attention to detail and fine dexterity and both hands can draw up the doses just fine and label them and follow the directions. And not everybody is good enough to do that either, so be careful who you choose and trust to do your doses, because it does need to be somebody who has good attention to detail, who isn't looking at their phone the whole time at the same time they're doing this. So, not a millennial. No, I'm just kidding. No joke. But, somebody who you're like, yeah, you pay attention, you can do this. I'm not a teenager, obviously, like today. We wouldn't trust any of my kids to do this. There's no way. Not yet. So with the primary allergy mixtures, there's the foods, and like I've mentioned, there's 13 subgroups, and then there's also gluten, which is a food, but I see it as a isolated antigen. Next week or the week after, we're going to make a seed oils group. Like I said earlier in the weekend, I've encountered people who appear to have, they do continue to have reactions to like processed foods, let's say, is a big one. Or they'll tell you, you know what, I react to sesame, I am reacting to flax. I'm like, all these other allergies went away, but they react to a seed or a nut, which is also a seed, or something like that. And I'm like, okay, this is another outlier situation where perhaps I need to present the antigen in an isolated sort of naked form. Gluten proved to be the case. Like the whole grain production of antigen mixtures with foods doesn't work for celiac disease, but using gluten in isolation does. And I think maybe when people eat wheat, the gluten gets separated out as a unique antigen molecule after digestion, perhaps, and then they react to it. So if I use the whole grain as the antigen, it doesn't have the gluten presented in the right format. That's the way I make sense of it. So I had gluten by itself as an antigen, and it totally fixes celiac disease. It's amazing. So people do not have to suffer with celiac disease if this might work for them. And I encountered citrus reactions, people that would, all their other food reactions would go away, but they would eat lemons, oranges, limes, whatever, and have a reaction. And then it occurred to me, maybe they're reacting to the essential oil, because that's not well represented when I used the fruit. I didn't use the skin. There's a lot of oil in the skin, right? So I used the fruit inside of the citrus fruits, and then I tried using the essential oils mixture for those people, and they stopped reacting to citrus. So it's another case where the presentation of a particular molecule that normally exists within a whole complex organism or a complex of molecules has to be given in a specific way. So we're doing that soon, this month, with the seed oils, and I'm hopeful that it's going to finally work for some of my failures, right? Like I focus on my failures. People who do great, it's weird. I just sort of am like, okay, cool, great. And I don't really revel in it. I don't pay this much attention to it until they bring it up to me later. I'm like, what have I not fixed yet? And that's kind of where my mind goes. So I'm really hoping that this will be another solution for some more of our patients, these people who don't seem to respond. And I think it will. Within the allergy mixtures too, so we have the foods. We're going to have the seed oils, one to include in that. The environmental has 7 or 8 subgroups: mold, animals, trees, grass, dust, mites. I will make a comment briefly on the mites part of that. And I made a mites submixture because there are lots of different kinds of mites that live on our skin endemically. So that everybody's usually, thinking of dust mites, Dermatophagoides genus, Pteronissus and Farinae. Those are the common ones, house dust mites. But people will become allergic to the mites that live on your skin. And those patients are the most miserable I have encountered, pretty much. They itch like crazy. And in their sleep, they will have to wear mittens to bed because they will claw their skin open in their sleep. And clues are sometimes that they itch the most under their socks. I don't know why. There's certain, I think it's hotter and sweatier. You just think about ecosystems and environment, right? Yeast likes to live in hot, sweaty, dark areas, or hot, moist, dark areas, armpits, under the breast, the groin, things like that. And certain mites live in other places. There are certain mites that just live in your eyelashes and eyebrows. And you'll get people that have this constant inflammation around their eyes or their eyelids. They'll get what seem like styes. They wake up with crusting every morning. It's like their eyes are always inflamed, and they don't react to mascara or makeup or whatever. I'm like, okay, maybe there's that you're reacting to the eyelash mites, which is a thing. If you look up online eyelash mites, you'll see little microscopic photos of these suckers. They're super creepy. And I love showing it to my patients. They're like, those are on me. I'm like, yeah, get used to it. You are a walking ecosystem. Those of you out there who have never heard of the book 10% Human, I strongly urge all of you to read the book 10% Human. It's written by a zoologist, so it's not written by some biased medical practitioner who thinks they're right about everything, like me. So it's a zoologist who's just looking at the complexity of the ecosystem that is every living animal system and how important your ecosystem is to you and your health. She even talks about biofilms. In integrative medicine, we've developed this idea that biofilms are somehow a bad thing, but biofilms are an important factor in you maintaining your ecosystem in a healthy way. And they are where your ecosystem lives and resides. And if you ever come to Hawaii and you do a night dive with the manta rays, which I highly advise people to do, it's beautiful. These 12-foot wide manta rays will swim right past you, and it's just the most insane thing ever. They tell you very clearly, do not touch them. You're very tempted to reach out and just kind of touch them. But what they've discovered, what the marine biologists have discovered, is that they have a biofilm that covers their body that protects them from the microbes in the water. Their microbial ecosystem, their little army of microbes that are friendly, create a barrier between them and pathogens. And I just want you all to think about that when you're talking about stripping the biofilms out of patients and getting rid of their microflora and whatnot. Sometimes that's helpful, and I would just suggest doing it for like a week or something, because after reading this book, I was like, yeah, that makes sense that it can be harmful. And I had patients where I would try to work with biofilms in the past, and sometimes they get worse. And like Dr. Raid mentioned, which I really appreciate, the belief that your patient could get worse first as a positive sign of healing and wellness, I do not find true. Let's say I don't think we should expect or advise our patients to get sick before they get better. But if you see that, you're like, okay, maybe I've disrupted this person's ecosystem in a way that is not better. Okay, so might have better luck focusing on establishing tolerance for the organisms in that person's ecosystem and within their biofilm. But if you like drag your finger on the manta ray, you could make it dead actually over time, and they'll tell you that. So it's a fascinating book. I encourage everybody to read it. The reason it's called 10% Human is because what she says is only 10% of the cells that make up your body are human. 90% of the cells that make up you are microorganisms. They outnumber you 9-1. And that's fascinating. And they also make neurotransmitters. They make vitamins for you. They detoxify chemicals for you. They methylate things for you. And so that's why sometimes when you put a patient on antibiotics for a while, all these weird new things begin to happen. Like now you seem like you have an MTHR defect. Well, yeah, they always did, but the bacteria in their gut methylated stuff for them, so it was okay. And you start to see people as this complex system of friends that help each other out. It takes a village, and you are a village. Actually, you're more like a country if there's a trillion of you. But it's pretty fascinating, and it really opened my mind to thinking about what I do with LDI in a more effective way, too. Let's answer this question. What if a person is also being treated? Oh, I already answered that. Okay, good. More questions coming in are great. I got to fill like an hour and 45 minutes.
Got a question.
Okay, good.
In the great scheme of things, you started this with LDA and diluting it out on your own, and since then you've developed all these other antigens and along the way.
Right.
And along the way you've created in your own mind, I'm sure, this algorithm that you use about what to use when.
Right.
For those just starting, and we already have this panoply of is there advice you can give about rather than wander down the aisles of confusion at GNC trying to figure out what thing, do you have any hints as to making a sophisticated wild ass guess as opposed to wild ass guess?
Exactly. Yeah. The thought is, as Dr. Barschmidt pointed out, like I started with my own thoughts and creativity, and I learned LDA, and I took the concept and started to expand and apply and experiment, and then over the years collecting more and more antigens. Like in 2009, I acquired a yeast mixture and a mycobacterial mixture. And now we have at least 70 different mixtures of things, all kinds of microorganisms and allergens and whatnot. And I'm sure there are more to discover and develop, like the seed oils submixture coming up. And the question is like, well, so you over time started to develop a sense of, I over time started to develop a sense of what I might want to try first based on the illness, the diagnosis, the situation, the symptoms each patient has. And what I've tried to do to help give you guys a head start so you don't require a decade of experimentation to get to where I am now is in the practitioner manual in the back. There are disease categories that give you menus of antigens to consider. So like gastrointestinal disorders, chronic fatigue situations, arthritis situations. So these are some big categories, neurological situations. And you can go to that and go, okay, these are lots of things you could try, and then go through the list and think, okay, what questions might I ask this patient to determine whether it's this or this or this? If it's an allergy case, it's usually straightforward. Here's what I react to. But then you do have to think about, well, are they reacting to chemicals in the foods? Or, there's some nuances there. With microorganisms, if the patient's ever been given an antimicrobial, like let's say they were given an antiviral for a while and they responded great to it, and then it kind of stopped working because probably the immune system overcame that, and you can't really get rid of a lot of the herpes viruses anyway, you can't get rid of, so they'll be in you no matter what. And that's the category where we see the best utility of LDI. But also respiratory viruses and whatnot. If they say, oh yeah, I was given an antiviral and it worked great for a while and then it quit working, like, oh, then maybe I'm dealing with a viral antigen. If they say I was given antifungals and I did great while I was on them, but I had to keep taking them and eventually I got elevated liver enzymes and couldn't take them anymore, and then all my symptoms just been unrelenting, like, well, that's a clue that you probably have a fungal antigen. Okay, so those are some of the most important questions I ask patients that have chronic mysterious illnesses is what have you taken that actually helped? And then I also ask about have you taken antivirals or taken antifungals, because if they say, oh yeah, I tried that and it did nothing, then that also helps me limit my suspect list, or at least change the way that I rank order it. I never take anything off the list of possibilities. I just shuffle them around in terms of what I think I would try first. So in the formulas lists, you can go formula by formula, and at the bottom it's here are the conditions or diagnoses or situations where I have seen success with this. And as those of you play with this and gather more experience, please send me that information if you try it for something new, some weird, obscure autoimmune disorder that I've never heard of, and it works. So like, for example, when Amy worked in my clinic, she had a patient with progressive external ophthalmoplegia. What was it? PEOM, progressive external ophthalmoplegia something. And or ophthalmic myoplegia. Basically, it was this weird neurological condition that was considered autoimmune, where she couldn't properly move the external ocular muscles and look where she wanted to look. And it also affected her vision and eyelid drooping and things like that. So that's not that different from like myasthenia gravis maybe. We also had a patient with myasthenia gravis. Both of these uncommon autoimmune disorders responded to the lime mixture. And I've also seen polymyositis respond to the lime mixture. Now, these are diverse things. But so this, in some cases, one particular antigen can cause a plurality of disorders that affect different systems, different tissues, and different people in a different way. So if you ever come across some weird, obscure thing, and you're like, it's not on your list anywhere or something, please email me and say, what do you think? And I may have had a case like, oh, you know what, I heard of this from somebody else. I just didn't put it in the manual yet, because I only update the manual every couple of years. Or I may just say, I've never heard of that, and then I'll research it. And when I research things, those of you out there who want to research things and figure new stuff out for yourself too, go to PubMed and type in the disorder and the words molecular mimicry, and you may get some hits and some clues as to, things that have been at least postulated as being related to this immunologically. And like, okay, cool, that's a good place to start. It doesn't always work out. Like most of those that I've found some primary literature suggesting molecular mimicry, it doesn't end up working. But it's a good place to start. Sometimes it does. Instead of every possible thing in the world, at least you can narrow your focus. The other thing is look at the pathophysiology of the disorder. And so like thinking of sarcoidosis, the reason I decided maybe mycobacteria was the thing is because it enters through the lungs. It always begins with bihilar adenopathy in the chest and the mediastinum. It spreads through interstitial. It can cause an effect in any tissue in the body, and there's granuloma formation. So granulomas are usually the result of inflammation of the immune system targeting a fungal organism, or tuberculosis. And tuberculosis is a mycobacteria, which is sort of one of those missing link species kind of ideas between fungi and bacteria, probably, right? With cell wall components that are fungal in similar ways at least. So I was like, well, then sarcoid seems like a mycobacterial thing, and I tried it and it worked. But think of the pathophysiology. I had somebody else who had Churg-Strauss syndrome, and I was like, oh, I've heard of that, but I don't remember. And I looked it up, and there's granulomatous inflammation of the tissue pathology. And so I used the mycobacteria in that person, and it seemed like it was working. I wish I could tell you it worked for Churg-Strauss, but that guy disappeared on me. He had taken a couple of doses, and it looked like, it seemed like maybe there was promise it was going to work, and then he either moved away or something happened, and he didn't keep coming back for treatment, so I still don't know. Similarly, there was something along those lines that I can't remember now what it was, but I'll come up with it. Other little odd things, and I research, I'm like, oh, this sounds related to that too, and then you try it, and you find out, does it work, does it not work? But look at pathophysiological factors that kind of indicate the type of immune response you're dealing with, and sometimes that's a clue to at least the category of organism you might want to think about. And if you can find a good molecular mimicry hit on PubMed with some primary literature that gives you the right target, that's a nice shortcut. I have a great textbook that I got, I asked for Christmas several years ago. I think the author's name is Yehuda Schoenfeld. I'm pretty sure the last name is Schoenfeld. He's an Israeli researcher, microbiology researcher, but he got interested in this connection. So between microorganisms and autoimmune diseases. And the whole book is published primary literature that tries to link these things together. And I thought, I need that textbook. That'll have all the answers in it. Unfortunately, it doesn't. It has very few answers in it. And so what I learned was a lot of this primary research is fraught with error, because when you take things apart like that and you see little tiny responses, that does not often extrapolate to the whole organism and how it's behaving. And a lot of integrative medicine is based on that. We have these biomedical studies in vitro, in tissue cultures. Oh, this happens when you do this. I'm like, but that's different when you swallow it and it has to go all over your body and you have a living ecosystem involved. It doesn't always translate to clinical response. And so the book is fantastic. It's all this information, but every time I've gone to that textbook to research a possible antigen, like for my diabetes, for example, or for other things, it hasn't so far worked out. And so it's frustrating. It's like, where do I find the truth? You just find the truth. You just experiment. You flail about until something works, which is, I think, the human history in a nutshell. It's sort of where we've always been. Is there a number of antigens beyond which you think it's not helpful or confusing? No. So far, I would say there's not a number of antigens. We talked about this some over the weekend. Like, is there a point at which your immune system just can't process the information? And I thought about that years ago. But that kind of flies in the face of how LDA works in the first place, and how LDI works in the first place. By our history, we use these very large mixtures of diverse antigens, and as long as the one you need is in there, it has worked very well. And I think our immune systems are well adapted to processing millions of antigens at once, because you just walk through a thrift store, for example, or go out in the woods at some point in time, or go to a concert around, especially like a Grateful Dead concert or something, right? You're going to be exposed to all manner of people wearing perfumes and having fabrics and different microflora and coughing and sneezing and smoking this or that. And your body's immune system is always processing everything in that regard. It has to be. It's not like it takes a vacation. And so I think we are well adapted to processing all this information in that way. It's just if the right thing happens to be there, you seem to get the right response. And so far, I do not find that there is too much. And I have wondered whether there's any value in making a LDI test dose where I just take a sample of everything that I have and put it together and give it to people at, maybe I started at 10C or something, and just go, here, let's just try everything everywhere all at once, which is a great movie if you haven't seen it. Nobel or Oscar winning movie, I think. So I thought about that, and I'm like, I really don't want to screw with that, because like, if you do get a response, are you just going to keep using the whole mixture? You possibly could, but it's very common that people have more than one immune reaction, right? And so then you'd be like, ooh, these problems got better, but I don't know which antigen is doing it, and I don't know how to divide this out and which ones to manipulate further. It's going to breed a lot of confusion at a certain point. So when I combine antigens together, when I'm experimenting with a patient, like you get somebody who has the fatigue, the brain fog, the unexplained migrating pain around their body, a lot of these people, there are multiple causes. I will use 2 or 3 antigen mixtures at a time. And for me, it's not because I don't think the immune system can process more data. I think it's because I can't process the data. I'm not going to be able to tell logically which things I have to manipulate. And so there's a limit that I have set for myself. But y'all can experiment away and see if there's a functional strategy that you discover. In the case of a patient with EOE, where foods are most reactive, several of which cause anaphylaxis, could you start with other less reactive antigens, such as environmental chemical? That's a good question. If you control one or more other inflammatory responses, will the ones they still have be mitigated in the process? So my belief, that's a great question. I think about this occasionally. My belief is that the immune system as a whole will settle down some in terms of your overall inflammation, and therefore the patient's experience of their illness will definitely calm. That does not appear to change the LDI dose they eventually respond to for the other remaining allergy. And I can say that with confidence because I very often use one of these things at a time. And I'll phase it in, but sometimes, we'll have a patient who's on an effective LDI dose, right, for foods, and then we use the environmental, and then when we find a success with the environmental antigen, it doesn't change their food dose, right? So that stays the same. And so we're talking about this in the other direction, but we can't really do it in the other direction. So that direction, I can tell you, fixing one does not change the set point for the other when I have gone this direction. And so I don't think that's a problem, but it is a help. And so if the patient in this scenario is terrified at the prospect of doing food testing and challenges, right? Like, well, I don't know, it really scares me, I don't want to do that. Then I go forth, like you're suggesting, well, let's work on these other allergies first. And there are a few benefits to that, at least 2. One, they get comfortable with the LDI process, which is a whole learning curve for everyone, for practitioners, for patients. Like, this is a whole new thing. It's different from any other therapy you're going to do. It's weird. The communication process is different, and there's a lot to be said for them just getting comfortable with the process and the communication. The other is that it gives them a sense of safety, security, and confidence. So if you get their dog and cat and grass allergies to go away, then two things happen. One, they realize the therapy actually works. And two, they realize that wasn't so hard. It was safe and I did it. Now I feel like I can do it for foods. And so I do that a lot with people. And again, it goes back to like Dr. Raid talked about, and I've mentioned the patient psychology. Like I will say, okay, you have all of these problems. You have 5 things that are potentially immune related that I might treat. What's your priority? Like which one do you want to try first? And give the patient the right to choose and the agency and the authority to be involved with their own care decisions, right? People like that, I like that, and it works better in terms of the collaborative approach. So I do that a lot. And sometimes they want to start with the most severe thing because it's what bothers them the most, and sometimes they want to start with something that doesn't scare them, and that's great. Like whatever you want to do, doesn't matter. Odds are we're going to be working with this for the next 6 to 12 months, and hopefully we get everything figured out eventually. It doesn't matter what order that happens. And you just go where you go. The common kind of philosophical thing I take to saying a lot is that rivers aren't straight, and rivers aren't straight for a reason. You may say, I want to get from here to there, and there's a straight line, and I will insist on going in a straight line. Rivers try that, and they fail. Canals go that way because humans dig them forcibly through barriers. But rivers eventually get to the ocean, but they just go the way they can. And that's what we're stuck with too, throughout our life journey in general, but also through this treatment process. And EOE, you mentioned, it is most commonly a food sensitivity, but if that doesn't work, think about yeast, mouth flora, some other organism that maybe there's passing through their esophagus. You'll also see people with eosinophilic colitis. That is less often food related. I think you might have better success with yeast or parasites or something downstream, but you'll also see foods resolve that. Have you found that your environmental chemical mixtures may have some limitations for different exposures or environments need to expand for disease? That's a good question, and yes, I think so. We used it for some local Hawaii patients, and there were it seemed like it wasn't working for some of their local allergies, so then Jeanette and I wandered about our island and collected, mango and coffee and some of the local flowers, the tea plants, like tea, which is the ones they use to make leis and stuff, not the tea that we drink, and some of the other local flowers and different things, and we just kind of put those together, and so we have kind of a local tropical plants mixture that's within the environmental. And no, it's listed on the slide actually. So we did that, we did our own collective. If anyone out there lives in a particular region or country or other part of the world where our environmental mixture just does not seem to be cutting it, if you want to gather some local environmental allergens or antigens, or if you have some in a production form, like from a company that makes them standardized, whatever, if you have something that might benefit everyone who uses this, send it. We will remake the environmental mixture. We've had to remake the environmental mixture a few times. It's the one that I've had the most trouble with in that regard, and why I think it works less well than the chemicals and the foods, because there's just a lot of biological diversity in the world. So that's the one where I've seen the issue, not with foods or chemicals per se. You will probably, if you use this a lot for a lot of people, which I imagine those of you who embrace it and go home to play with it will be finding that you use it a lot, you may discover there's a patient here and there that has a specific chemical allergy that does not resolve with the chemical mixture. And if that happens, let me know what it was, because maybe it's something that I know I did not include, or just make it yourself, right? So if they say, I react to this particular kind of shaving cream or this particular kind of leather treatment stuff, then just take a sample of it and dilute it like it's an autologous or a custom LDI mixture and sterilize it through a filter. If you don't have that equipment and you don't want to mess with it, just mail it to me. Mail the sample of whatever to me, and I'll process it and send you back a concentrate. I'll keep some for myself to incorporate into the chemical mixture eventually, which is kind of a pain. Like every time we remake a whole mixture, then I have to redo all the dilutions and also redistribute it to everybody who's using it, a couple hundred people. So it's not a small thing, and I don't want to do that very often. I'd rather get a collective of things. So if you have a isolated chemical or something that the person's reacting to, it's a lot easier to just make an isolated custom mixture for that person, because it isn't very common and it probably isn't going to be necessary for very many people. So there's a point at which it's not worth all the effort that is involved in remastering the whole mixture, okay? As I go down this list, the chemicals, I made an essential oils mixture because of like the whole citrus thing, and I would find people who would say, oh, I put tea tree oil on once and I had hives, I went into anaphylaxis, or thieves oil, or frankincense, or whatever. There's all these things you can react to as well. A lot of allergists will tell patients, you can't, there's no such thing as a chemical allergy because you have to react to a protein. This is a very common dogmatic belief in the world of allergy. Allergies are protein based. The antigen has to be a protein. And I'm like, well, did you ask them if they believe in drug allergies? Like, do you not believe drug allergy is a thing? Which sounds like, malpractice waiting to happen. You go, oh, there's no such thing as drug allergy. Well, drugs are chemicals. They're foreign molecules people created. And there's no protein in them for the most part, unless it's one of the biologics, right? So that's ridiculous. You can have an allergic reaction to one of your own hormones. You can have an allergic reaction to any chemical or thing. So the essential oils, not being proteins, they're a different macromolecule. You'll see people who react to them, and I saw people who reacted to them, and I'm like, that's not covered by anything I have, so I had to make it. And through the thought process, I had patients who were distributors for doTERRA and another one for Young Living that was out of state. And I was like, can you do me a favor and just put like a couple of drops of every single formula you have into a vial and mail it to me? And then I had them do the same thing, a couple drops of doTERRA. And so the essential oils mixture is all of those oil products from both of those manufacturers. And it's very broad, and it tends to cover those things very well. We're going to be doing the seed oils in a similar fashion. And then latex. I made the executive decision to keep latex as an isolated LDI antigen by itself. The reason I thought that was because latex allergy has become so common in our population that I believe it has probably separated itself from chemicals. Latex is a naturally occurring substance. It's not a man-made chemical. And so it doesn't really fit logically in the chemical mixture anyway. But when I find people that react to latex, there's a fairly good chance that dilution they need for their latex allergy will not be the same as the man-made chemicals. And so that's why it's separate. And so I think we were talking this weekend, and somebody was like, well, the chemical mixture worked great for this person except for any stretchy fabric. Stretchy material they would wear, they still react to it. And I'm like, then that's probably latex. And so you might use the latex for that and find out. And it's funny, people say, well, I don't know if I'm allergic to latex or not. Then get some latex and put it on your skin and find out. It's really not that hard to tell. Like, I have people that say, I think I'm allergic to cats, but I'm not sure. And I always say, next time you see a cat, pick it up and rub it on your face, and you will know. And the cat will know also. It does not like you, because cats are not like dogs. But you can find out through exposure testing. And latex allergy is not that common anymore, at least not in my practice. I have maybe one person that I'm using the latex on. I think it's because we kind of as a society decided we're going to really limit latex exposure, especially hospitals, medical stuff, and then went to vinyl and nitrile. So now I see people that are allergic to nitrile instead. And nitrile glove material is in the chemical mixture. That is in there. Cannabis is another kind of interesting isolated allergen I made because I had a patient once who was growing marijuana for his wife, we had on medical marijuana for some of her issues, and he would get blisters wherever the leaves touched him when he was cultivating, so I had to wear gloves and be careful. And so they brought me plant materials, a little bit of the buds, the leaves, the stems, the roots, who knows what part you might react to. And I made a dilution from that, and it took away his allergy at around like 8C, if I recall. We also have, this not on this list, we have a mixture that I think I call PIO, which is poison ivy and oak. So you will occasionally see people who have a severe allergy to poison ivy, poison oak. There's I think, more direct irritant kind of reaction that everyone is susceptible to, kind of like bug bites, similarly. My internet connection's unstable. Well, that makes two of us. Hopefully it'll hold. So you'll see people with mosquito bite reactions or other bug bite reactions that just blow up on them, and they go out of bounds with the swelling and the redness, and they might have even systemic illness feelings from all that inflammation. The environmental mixture has bugs in it. I didn't put that in the subgroup listing there, but there's one that we just call bugs that is a bunch of different insects and arthropods, arachnids included in that too. So that has so far seemed to work quite well for the people with those insect bite reactions. They calm them down nicely. And I don't know if it's really a direct effect. I haven't broken out the bugs mixture to just try to treat that in isolation, or if it's a secondary effect to helping their allergies in general, right? Because if you just get their primary allergies under control, their whole immune system tends to calm down, and maybe then they're just not as hyper-reactive to that sort of new introduction of bug spit into their dermis, which is what's happening. Similarly, like the alpha-gal reaction, many of us are seeing patients with that. It's different. The alpha-gal reaction, lost Zoom. Buffering. Familiar with the buffering process.
We need to kill an hour and 15 minutes anyway. So.
Lots of buffering, yeah. Well, if people run out of questions and stamina, we'll just wrap it. I'm always more awake when I'm talking than when I'm listening. It's a lot harder to stay awake when you're listening.
Uh-huh.
Ooh, this one's taking a while to reconnect. Is anyone else on? No one's on the Wi-Fi. Or Jeanette? Oh, it is, but I can see if it'll connect to my hotspot. Let me make sure my hotspot's on. Maybe that's what I should do anyway.
Is everybody on the airplane on the phones?
I'll try my hotspot since this is taking too long. Alright, let's see if it'll connect now. We have times at our house where, oh, there we go.
Recording in progress.
Alright, let's make sure I'm live. Okay, sorry about that. That was the longest time it took to reconnect.
Yeah, well, your lights are blue.
I switched to my hotspot, so maybe that'll work better than our Wi-Fi. Okay, what was I ranting about?
Alpha-gal.
Alpha-gal, thank you. From the locals. So, alpha-gal, my viewpoint of alpha-gal is that the alpha-gal in the tick saliva, this enzyme, alpha-galactosidase, acts as a catalyst for the development of the allergy. That's what I think. I think mosquitoes and other blood-sucking arthropods have other things in their saliva that cause a histamine release locally, right? So that the blood vessels dilate and it delivers more blood to the bug so it can get more of what it wants in the process. I think that's just an evolutionary adaptation. So in the tick, the alpha-galactosidase is probably something that helps break down ground substance or other matrix in the dermis so that they can get more blood flow into their face. That's probably what it's for, but it seems to be immunogenic. You know, some things just really simulate immunogenic reactions, like adjuvant substances they put in vaccines, right? They put things in vaccines to intentionally piss off your immune system so you have a more robust immune response to the thing in the vaccine. The problem with that is that you may very commonly nowadays incur unwanted, unexpected immune reactions to other things. Like now you have chemical sensitivity, now you have Lyme disease symptoms, now you have herpes outbreaks, now you have rheumatoid arthritis following a vaccine, right? So that existence of a similar adjuvant substance in the tick saliva is my suspicion as to why these people develop new allergies that they didn't have before. Then the question is, or the comment would be, well, but this is just meat. And I'm like, yeah, but that's also where they're, and it's usually just mammal meat, right? Not necessarily fish, not necessarily poultry, but maybe some, but a lot of times it's pork and it's beef and it's mammalian meat, let's say. But if you think about it, that's where you got exposed. So the alpha-gal and the tick bite was also internally introduced to mammalian meat, i.e. your own muscle. Your own body tissue is mammalian meat also. So to me, that kind of is how I make sense of it. The gist of it is, like the key point is, the alpha-gal instigator, that being the catalyst or the thing, is not relevant to the treatment. It's the fact that they're now allergic to meat. So all you have to do is give them the food mixture. The fact that alpha-gal is what instigated this reaction versus a vaccine or life stress or a surgery or what have you does not matter. How you got where you are is not as important as how you're going to get out of where you are. And I try to people like the whole catalyst idea. I talk about like a car accident, a car crash, right? Somebody hits you with a car and you're left with a broken leg and a head injury and maybe a punctured lung, right? Well, getting the make and model of the car or getting the driver back does not help you solve the problems that you now have. And in many of these cases where we treat people with LDI, people really want to focus on the story of how it started. Like, well, I had strep throat, and then all these problems started, so I must be reacting to strep, and that's usually not the case. Or I had a case of COVID, and then I developed a joint pain and fatigue and weird numbness in my feet, and it must be the virus still. It isn't. Those are not symptoms of coronavirus. Coronavirus is like respiratory stuff. So when I see people that had COVID and then they have persistent respiratory symptoms, they may respond to the URI mixture because those symptoms are associated with a respiratory virus. But when they say they have these extrapulmonary symptoms in other systems of the body, I just think about what those symptoms are and what the typical antigens are, and that's what ends up working. So for the whole alpha-gal situation, the fact that it was a tick bite that caused it, I was in Texas and it was the Lone Star tick and the whole bit, whatever, does not matter. All you need to know is what you react to now, that's the antigen. And that's an important thing, because I'll have people that really push, but it's alpha-gal, it's alpha-gal. I'm like, you're not reacting to alpha-gal now. That was the catalyst, that was the adjuvant that made you react to meat. So the thing you're reacting to is the meat, that is the antigen, that is what we have to use to treat you. And it is not different than if your allergy had been incurred by some other process or exposure. So keep that thought in mind. Would that concept apply to creating an autologous mold mixture with the patient's house dust, for example? That's a good question. So we did notice that a fair number of patients we treated with the environmental mixture seem to continue to have allergy problems in their home. And then it's a matter of like, well, what is it? Is it some dust mite that you have that other people don't have that wasn't in our mixture? Is it some other, particularly dust is this complex mixture of who the heck knows what, right? Your dead skin cells, the cobwebs from the spiders in the corners, there's all kinds of biological and non-organic materials in house dust. So what we did was we had probably 15 to 20 of our patients that lived in different regions of the United States, or maybe some out like Canada, maybe some outside North America. I can't recall if anybody was outside North America. I told them to like go around their house with either a baby wipe or a piece of gauze or a Kleenex and just wipe behind your TV set, under your couch, your closet, get good gucky nasty samples of all the house dust in your domicile, and then mail them to me. So of course we're getting weird crap in the mail again. And then we put it all together in like a jar or Ziploc bag with some water and weighed it and then drew it out. And so our environmental mixture, this is one of the multiple times that we've remastered the environmental mixture. We included the house dust mixture. That is in there too. And it should be delineated in the formulas list that that's there. And I don't remember if we fully described that or not, but I think so. So we thought about that too. And you could do a custom mixture for one person in their home if that seems to be the case. I will momentarily be picky about word usage. Autologous means you take a sample from the person themselves. So this is a sample from the house, the environment. I call that a custom LDI mixture, just so you know my stance on that. But I know what you're talking about, and I will forgive you. My wife says this all the time too, and I only correct her about a third of the time, and only if she seems like she's in a good mood. She knows my stance on it, and it's not going to change. Neither is hers. So I know what you mean, but it's a custom thing, and things like that you can give to other patients because it's not somebody's particular microflora. You don't have to worry about transmitting something. So we have this mixture from other people's houses, and we use it, and it's in there, and it's still, the environmental mixture has the highest failure rate of all the allergens that we use for various reasons that I don't understand. But other key points to the allergies, or for the allergies here is, and I tell people this all the time, you cannot react directly to the dose. You must also be exposed to the antigen that it is treating. And when people are dealing with allergies, that behaves differently than people who are dealing with internal antigens. So if somebody has Lyme disease or they're reacting to candida or herpes viruses or something, the antigen, which is the organism, the microbe, is ever present. They're always exposed. So the exposure is not a variable. In those cases, when you give them an LDI dose, if it's too strong, they will flare. Their symptoms will flare up within 48 hours because the exposure is already present. When you're dealing with an allergen, it is different because they may be avoiding their exposure, okay? That's why we have to do the test exposure a week later. If you have somebody, though, you suspect with allergies where the exposure is constant, like mold or dust within their home, chemicals within their work environment, pollen during pollen season. You know, there's a lot of times where environmental allergens are present. You can see a flare begin within the first 48 hours because the exposure is present. And that is something that would happen, and that's important to understand. But the patient will be like, oh, the dose, I reacted to the dose. Like, you didn't react to the dose, you reacted worse to the antigen that you already react to. And it seems like it's splitting hairs, which I don't do, you know, but it's an important distinction. Like, you don't react to the dose, that means you must be being exposed to the allergen continuously, or there's another explanation entirely. But this is just a fact of how LDI works, because otherwise people would be reacting to doses all the time, and it would be chaotic and haphazard, and it wouldn't make any sense. You know, so you really don't see people react to the doses themselves. There must be also co-exposure to the antigen, which is why if they are successfully avoiding, the only way you can tell if an allergy dose works is to have them do an experimental exposure a week later, and then you can tell by comparing that to their usual reaction. I will also comment, that is something that patients don't always understand. They'll say, oh, I did my test and I got worse. And I'm like, okay, what do you mean by worse? Like, was this definitely worse than your usual reaction to the same thing? Well, no, I reacted the way I always do. Well, then don't say worse. Like, so again, word usage and word meaning. Like, granted, you felt fine before the exposure, and then you had the exposure and felt worse. That just means that you reacted to the exposure and the dose did not work. But if you tell me that the LDI response was quote unquote worse, in my mind, that means the dose was too strong and I have to back up. And then I explain them, and they go, oh, okay. That is explained in our long patient handout that you should all give to people, but it turns out a lot of people don't read it, or they don't digest it or understand it. They forget that particular detail because they're really living in their own body and they're living in their own experience, and to them, they ate it and they got worse. True. So you have to really pin them down on what that word means. And like, how was it worse than your usual reaction? Well, normally I get a stomach ache and I feel kind of nauseous and it goes away after an hour. This time I had horrific stomach pain and I threw up. Okay, that's worse. Like, you know, to me, that counts. Yay, that's worse. I believe you. Let's back up, right? But you need those details or you'll make the wrong decisions. And it's okay to make the wrong decisions in a way that's harmless. Like, okay, let's just wait and back up. That's pretty harmless, except you lose time and money and you may lose their attention as well. What you don't want to do, like Dr. Raid mentioned a number of times early on, I did have some practitioners out there who I heard about from their patients that were just flaring them over and over. And they would give like somebody the lime mixture or the yeast. These are the ones where it was the most common. And the patient would be like, well, I was working with him and he gave me like an 8C dose and I got worse. I felt definitely worse. And then he told me, oh, that's good. That just means it's working. And he gave me a 7C dose, which is stronger. And I flared for even longer. I'm like, well, yeah, that tracks. That's how that works. And then he told me I had to take a stronger dose, went to 6C. He goes, oh my God, I don't want to do this anymore. I'm like, who was this you're working with? And so there's one particular person I won't mention. It was a chiropractor on the eastern side of the United States. And I found out and I emailed the person. And I said, so I had a patient, I found out that you were kind of following this one. I just want to let you know that that's not how this works and you're going to have bad results. And what you want to do is like back up and go weaker. And so that's not the way this works. You're just going to make people worse and worse and worse, which is not only going to be bad for your business, but mine, So, and his response was, who was it? Who was the patient? Who told you that? And I'm like, that's not really important. It's the concept, it's the process that you need to understand. What you're doing is not the right way to go about this. And it kind of went nowhere. He just was unwilling, like, okay, well, cool, then I'm just gonna make sure anybody asks, don't go see that person. Like, that's the problem with selling pianos, is some people are gonna like use them to, I don't know, crush people out the window. Because you can kill somebody with a piano. I saw it in a cartoon. So that's problematic, and I haven't heard those stories in quite a while. This was the early years where I myself didn't have the experience and the confidence to sit here and tell you things like they were factual, or like I've done this now 1,000 times and I feel like it's probably true. So it was early, and I think a lot of people had a sense of freedom to experiment or whatever themselves too, which go right ahead, that's fine. But like Brian said, if you're making somebody worse, you're doing something wrong. Don't think this is the way. I'm going to keep going that way. You're going to lose patients at a minimum, and you might lose your license or something else. And then they'll be like, what were you using? Oh, low dose immunotherapy. Well, what's that? And let's go after the guy that told you to do this in the first place. can't help it. But that's something you want to understand. You know, you want to follow some of the guidelines that Brian and I have laid out. You want to be cautious, rational, scientific, reasonable, and I think you'll do great. Where are we at here? So there's known allergens only. I want to say, like, down on this list, have them test foods from their known allergen list. It is irrelevant to test a food that you've either never eaten or you've never had a reaction to. And this mostly happens with patients, parents of children as the patients. So they'll have a child, like an infant in particular, who hasn't really eaten a lot of foods yet. And they go, oh, I know they react badly to chicken and to like sweet potatoes or whatever. And then I'll go, okay, so after they take the dose, you start doing test exposures. I'm like, okay, can I try this? I'm going to start with these foods that I don't know if they're safe. I think they're probably safe. I'm like, then that's not relevant. Like, that's not going to be helpful. Either they're going to react to it, and you don't know how they ever reacted to it before, so we don't know if we've made that reaction worse or if it's the same, you know, or they're not going to react, and you might think, oh, well, the dose is working, because that's not known information. So you want to use known allergens that have a consistent history of reaction and that you see that's fairly similar along the way, and that's the useful information. People who say, well, sometimes I react to this thing and sometimes I don't. And I'd say, well, okay, like beef, for example. Well, if you eat grass-fed organic beef, are you okay? And then if you eat beef at a restaurant, it's bad? Yeah, that's pretty much what I noticed. All right, then you're probably either sensitive to corn, because that is part of the corn story, or chemicals. Like, it's not a beef problem, because you ate legit, natural, pure beef and you're fine. So it's something else in the bad beef that you're reacting to. Those are things you want to parse out for people. And corn, I don't know if I have a thing about corn itself. I don't think I do. I want to say something about corn. You will see people with corn allergy. You may be the person that has to inform them that they have a corn allergy. So here's what that looks like. My favorite test thing, if somebody comes in and they go, I think I might be allergic to corn, what you do is say, get some frozen organic corn and eat some. Because that is as far as I can tell, that is the cleanest, purest way to test corn. You could maybe use organic popcorn, but I think certain popcorns are treated with certain kinds of chemicals in the processing. I don't really know how they make it popcorn. If it's literally just dried out corn kernels, then okay, fine. But I'm skeptical or concerned about what else might be in popcorn. I don't know. So I tell them to get frozen organic corn. If something's frozen, they don't have to spray it with a bunch of chemicals for transportation to maintain freshness or things like that. It's just picked, processed, and frozen, and it's the cleanest thing you can get. And I'll have a lot of people now, because corn allergy has reached people's awareness. And there's a big Facebook group for corn allergy patients that's got to have 12,000 or more people in it now. Some of them discovered me several years ago. They're like, oh, I hear you do this thing. Is there any way you can help? I'm like, sure, I don't know, let's see. And what I learned about corn allergy through treating hundreds of these people now is that it is different in the way it behaves and manifests for different people, but also different from other foods. Corn is kind of interesting. If you read Michael Pollan's book, The Omnivore's Dilemma, he talks about how corn has been found to alter the valence of the carbon atom somehow. And it's unique in this regard. So when corn takes the carbon dioxide from the air and incorporates it into its structure, it somehow alters the atomic structure and the vibrational signature of the carbon atoms. I don't remember the details of what that looks like in terms of the atomic chemistry, but there's a term for it. I thought it was like carbon 13 to 14 or something like that. Anyway, it's like a different isotope. And so that carries through the entire food chain. You will see people who say, my baby gets a horrible rash, that like a mom's still nursing, right? And it's just breastfed baby completely. My baby gets sick, has a rash, digestive problems, like whatever, throws up. If I eat regular beef from the grocery store, but if I eat grass-fed beef, it's fine. And I'm like, cool, your kid's allergic to corn. or maybe chemicals or whatever, but there's all kinds of chemicals in everything else mom eats, and if they say that, or they definitely have found out maybe I can't eat corn itself, but you will see it transmit through the food chain. Milk, butter, yogurt, ice cream, eggs, chicken, beef. These are all animals, even lamb and things like that. They're animals that get fed corn. Pigs probably too, along the way. So somebody's like, I react to all these foods in this way. And I go, can you eat it if it's grass-fed? Can you eat it if it's wild? Can you eat it if it's organic? And they might go, I don't know, I haven't tried. And they go, well, go try and see. And they go, yeah, I can eat grass-fed beef just fine. Or I can eat wild pigs that are shot, but I can't eat bacon from the grocery store. And you're like, okay, why don't you try some frozen organic corn? And then they go, oh wow, that caused the reaction. That was even worse than the other things, but the symptoms should be the same. The severity of the symptoms might be amplified because it's a direct antigen exposure, but the severity will be worse with corn itself usually than it will be with those secondary, tertiary sort of exposures through the food chain. But it's fascinating, and once you are aware of this phenomenon and you start asking these questions, you'll see it. Like, Peter, do you see people that have this phenomenon?
A lot.
A lot.
And it's really confusing because then it amasses chemical sensitivity
Yes.
and environmental.
Exactly.
Horns and everything.
That's what I was going to go. So
Plastics and-
it gets worse. As Peter said, I'm like, yeah, exactly. So why I want to talk about corn sensitivity as a special case, because if you get good at treating these people, they will love you and more of them will find you, and it's super easy once you figure it out. So many chemicals in our modern world are made from corn.
The handles on paper bags have corn in them. I have a patient. She gets
Is
a
it the
rash.
handles on
She's
paper bags have
a
corn? Yeah.
detector. She's like, she'll get
Yeah.
a rash and she's like, that's got
Toilet
corn.
paper.
Yeah.
The corn allergic people that have a chemical extension will tell you, I can only use a couple brands of toilet paper, which is terrible to find out that
Yeah.
you have an allergy. It's probably not as bad as finding out about your latex allergy by using a condom, which I think is a horror story. But, the toilet paper, it burns my ass, until I find this one brand. I'm like, oh, you're allergic to corn. Because they all have different chemicals in them, but some of them are corn-derived chemicals and some of them are not. Like ethanol, right? Gasoline, so gasoline exhaust with ethanol, that'll bother people, but regular gasoline won't. It becomes very difficult. And people will say, I react to all these chemicals, all these things. And so what you want to say is, what happened first? Like, what are the first things you remember reacting to? And they might go, oh, beef or eggs or whatever. Like, okay, what about corn? Oh, I totally can't eat corn. I definitely cannot eat corn. Okay, is that worse than the other things? Absolutely. Great, let's start there. The reason I beat this to death about the differences with corn reactions is what you need to do in most of these people is give them the corn LDI first. Just corn, not the other foods. Because they may have other food reactions, but it is going to be obscured by the blizzard of corn reactivity that permeates the food world. And what I tell people is like, we have to wait till we get the blizzard to stop, and then you can find the snowmen in the blizzard. It is hard to see snowmen in a blizzard, and corn allergy is a freaking blizzard of sensitivity. And some of your mast cell activation kind of people will be corn allergic. It is one of the more common explanations. I react to everything. No, you probably just react to corn. and you'd be surprised, you give them the corn LDI by itself, and the reason you want to do it by itself, and it took me a while to sort this out, so I'm speeding this up for all of you, is that they will very, very often require a weaker dilution for corn than they do for everything else. All the other foods too. I'll frequently have patients who need the corn LDI at like the 10 to 12 C range, weaker than I need any food for anybody else, even anaphylactic. I mean, these people don't have to have anaphylactic reactions to corn, which is weird, but they might just have really annoying, really frustrating bad reactions to corn, and they'll respond at like 10C, 11C, 12C. The people who have, so here's how I break it down. The people who say they have obvious airborne reactivity to corn, so ask them about movie theaters, ask them about like other places where there's popcorn being popped. The break room at work, like, oh, if somebody makes popcorn at work, I can't go in the break room for 2 hours. Cool, you're allergic to corn. Corn mazes at Halloween, right? It's like Peter was saying, like it extends to the environment too. If you have somebody who lives in the Midwest, who lives in Illinois, Nebraska, Iowa, whatever, they're like, during corn harvesting season, I have to leave, or I can't leave my house, or I have to wear a mask. Oh, cool. And you might think, oh, let's try the environmental mixture. It don't work, usually for those people. Sometimes they need both. People can react to the corn itself, and they can also react to corn pollen, or whatever the grass spews out. And in that case, they do respond to the environmental mixture with the pollen reaction with the corn. So you sometimes need to use both to fix that airborne environmental thing. But you want to start with corn itself and titrate through until you find where their corn reactions appear to stop. And then you say, okay, are you still reacting to chemicals? And they might go, no, I'm not reacting to any chemicals at all anymore. Okay, great. Or they may say, I still react to fragrances. Like I still can't be around fragrances. I still seem to react to Band-Aid adhesives and diesel exhaust, and the common thread there is usually formaldehyde. But they will have, if they still have persistent chemical allergies, now you can implement the chemical doses and you know what test exposures to use. But if you hadn't started with corn, good luck. You will have no clue what to test them with because it's everything. And they'll also, you'll say, what about foods? You know what, I still react to eggs, you know, and then now the reaction is a little different than it was or something, or I still react to carrots, or I still react to whatever. And now you know where the snowmen are in the blizzard. Now you know what reactions to test, and you can implement the food minus corn mixture. So you may notice in our allergy lists that within the food subgroup, I have corn by itself as one of the 13 that's in the whole food mixture. But after I started working with more and more of these people, I realized that so many of them have a heightened sensitivity to corn that's separate from their other food reactions. I remade the food mixture just excluding corn. So the one that's called food minus corn has no corn in it, which might be counterintuitive. So you find their corn dose first, you're like maybe 8 or 9C, cool. And now with your other reactions to foods that are actually pretty banal, mundane, like, oh, you get a stomach ache from this, you get a little rash from that, you do the food minus corn mixture at like 6C or something where you would normally start and titrate through. And I'll have people that are like, oh, corn at 9C and the food minus corn at 4C, and everything's cool. And they also use chemicals at 5C or whatever. But you will see this. Now, many of you probably had no idea this existed. It's really common, and it's becoming increasingly common because we have taken to using corn to make a large percentage of our world. And that's not a good idea, it turns out. For some reason, it's kind of immunogenic. But luckily, corn has this weird carbon mutation thing. I don't know if it's lucky or not. Maybe it's not. But it allows you to sort through the logic based on what I was just talking about. And you'll see babies, people that they seem to react to everything. It's all the time, all this stuff. And you just go, you know what, why don't you test them with corn? You know, if they don't want to eat frozen organic corn, the other thing I have them do, back to the sensitivity profile. If they have a contact reaction or an airborne reaction, you want to start weaker and then weaker. So if somebody has airborne sensitivity to corn, like, oh, if they pop popcorn in the break room 20 feet away, I gotta leave. I start having burning in my eyes or coughing or whatever their symptoms are, right? Digestive reactions. You say, okay, then we're gonna start you at 15C. So unlike the other food antigens, very, very different. If they have an airborne reaction to corn, I start them at 15C and go from there. If they have a contact reaction, like try putting some cornstarch mixed in water and just put it on your skin. If you have a contact reaction but not an airborne reaction, I'll usually start at like 12C. So it's definitely a different level of sensitivity without the airborne reaction. And I've taken it starting at like 12C. And if they don't have a contact reaction either, but they have pretty annoying severe symptoms, I might start at like 10C for corn. So it's like 15, 12, or 10, based on whether they have airborne sensitivity or not, contact sensitivity or not, pretty bad reactions. If they have clear reactions to corn, but they're really not that bad, and they don't extend into chemicals and other things, you could probably start at 8C, 7C, 6C like you do with other foods. And in those people, I usually just use the food mixture and not the corn by itself, because odds are they have other food reactions too, and most of them will have their reactions all resolve at the same dilution. When I was treating people with LDA, so the LDA mixtures from the pharmacy, they don't break out corn. Everything's in there at a fixed ratio. You cannot treat these people. This is one of the categories where I realized something is different about this crowd. Like, I can't have you go through and their corn reaction might seem to stop, but they react to other foods, and then you go stronger with the whole mixture and their corn reaction blows up, and it seems like everything gets worse. And so there were years that I was treating people that I had no idea were corn sensitive. I did not know this existed. I didn't understand the different characteristics about it. But once you get a handle on it and you understand this, conceptualize what I was just describing, you're like, oh, I recognize this now. Now I see this pattern, I know what's going on, I have an approach to treating it. You will save these people from a miserable existence. I mean, corn is so ubiquitous in our world now, they can't go anywhere or do anything. And it's like the highly chemically sensitive people, similar situation, they can't go out in public at all. They have to create this oasis in their own home where they know they're not being exposed to the things that make them sick, and they're just stuck there. So the corn world is like that too, except worse, because they also can hardly eat anything. So it's something I didn't have a slide for, and I'm sorry, but I'm glad I had enough time to go through that, because you will all see it. You all have been seeing it, you just did not know. And so hopefully that will resonate with you, and you'll go to clinic next week, and guaranteed one or two people you see, if you see complex ill patients, will make you remember this conversation and like, oh shit, I think this person's allergic to corn. This sounds familiar. And then you'll do work with it a couple of times, and you'll figure it out and be like, oh my gosh, now this makes so much sense. And I wish I knew this 20 years ago, which I've thought so many times in my career. Like, oh, I wish I knew this before. But you didn't, you do now. You go what you go with. Chronic conditions, like I talked about with the yeast, you can maybe test them with sugar if they have a yeast reaction. Judge their personality type and consider placebos based on that. I know Dr. Raid talked about using placebos too. There's different ways to kind of go about it, and it's not a trick, it's not a betrayal. It's a really, really critical, important tool in medical science. The FDA isn't going to let you get any drug approved for use in humans unless you compare it to placebo and demonstrate that it works significantly better than placebo. That's just the way it is. And there's a reason for that, because the placebo response is very common. 20-25% of people probably have some level of placebo response. So if you think about it, those of us who prescribe medications for people, a significant part of the time that the medication seems to be effective, the medication's not effective, it's a placebo response. And that's like, for example, let's say a lisinopril study for high blood pressure. Let's say 50% of patients experienced an 8 millimeter mercury drop in their blood pressure taking 20 milligrams of lisinopril, and 20% of patients experienced that degree of improvement with placebo. So that tells you that the lisinopril only has a 30% effect, because you got to subtract the placebo. But if you give it to patients and half your patients respond, 20% of the patients who respond, or 40%, sorry, of the patients who respond, it's a placebo response. It's not a drug response. And you don't know who they are unless you gave them a placebo dose too, but we don't really have the ability to do that with drugs. We don't have the ability to do that with herbals. We could do it with IV therapies and things like that. You could give somebody an IV that's just saline and say, I'm giving you vitamin C, or I'm giving you whatever, I'm giving you battery acid, whatever. And they might have a response, and you'd be like, oh, okay, well, that was just your placebo response, which is a very mystical, magical thing. And I want you guys to be aware of it and use it to your advantage to help people, not just to piss them off, which can happen too. So the whole chronic infection thing, y'all know my stance on that. This is one of those issues people will debate for a long time. Is it an infection? Is it an immune reaction against the organism? Some people will say, who cares? If I just get rid of the organism, it's going to solve the problem. And that may be true, but what kind of collateral damage are you going to incur in the process? Think about that. The organisms that do benefit you, you're going to get yeast overgrowth maybe, just whatever. There's a lot of fallout. So for me, I would prefer to start with something that does not cause secondary problems or collateral damage or side effects, and so I opt for LDI first. Some of you will decide, because of your existing practice habits, I'm going to put them on this protocol that I like first, and the people who don't respond, I'll try that second. Cool. And some of you, after a while of doing that, may change your mind. You go, you know what, I think I'll start with LDI instead of this. And you'll come to your own point of comfort with that particular dichotomy. Would it be okay to share your placebo explanation video you mentioned with patients? It's on YouTube. So most of our videos I've made over the years, some of them are really old and terrible, 9-10 years old, bad production quality, and some of them we've remade in recent years. The placebo one is probably pretty old that we have, but it does exist on YouTube. If you go to YouTube and you put in Ty Vincent LDI placebo, you'll probably pop that video up, because I don't know what other video you would get. On our website, there are links to videos and things of that nature, so you can check out our website first. Go to YouTube and just expand that search, and odds are you'll find it. It's just one of those, like Dr. Raid talked about. He's hesitant to do it because you feel like you're being dishonest, you feel like you're being disingenuous, you're betraying their trust. I get that. I am less encumbered by the concerns of others or opinions of others, I guess, about me. So I was more than willing to do it in the name of science. I'm like, this is how science works. We got to figure this out. But I did have to develop a better way of discussing it with patients. So rather than just like, well, that was a placebo, so what you're telling me is bullshit. Like, you don't do that anymore. It's because they get mad. It's like, okay, look, what I will tell practitioners that is not in the video for patients is, if you give them a placebo dose and they tell you they have a response, I think what is really, really important to do procedurally then is don't email them and tell them it was a placebo if you can at all help it. Try to do this face to face and say, okay, tell me exactly what got worse from that dose and how you can determine that objectively. If they just say, I just feel worse, that's useless. Like, I need to know specific symptoms. The more objective they are, the better. How did you quantify them and decide they were worse? And sometimes people can't even really give you a cogent answer. And you're like, well, that sounds like everything's the same to me. Why don't we just try the next dose and see how that compares? And if they'll do that, great. And you don't even have to tell them it was a placebo. And if they take the next dose and they're like, same thing happened, I'm like, okay, good. Then now we know that that's not really a response to the dose, because different doses are going to affect you differently. And most of the patients I give placebos to, I never have to tell them it was a placebo. I use it as a tool myself to have clarity and certainty about what's causing what, and I don't even have to tell them. And we proceed from there in some manner, and we find where they respond, and it's nothing. It's in the past, it was just a tool I used for me to help that person. If they insist that they overdosed, or they were overdosed and they overreacted and they want to back up and whatnot, and you're like, okay, you get to a point where like I have to break the code on this, and I have to tell the patient that was a placebo. Get them face to face or Zoom to Zoom, like I do. I'm like, okay, tell me how they were all worse. How long did that last? Is there any other possible explanation? And if like, you know what, they all got kind of moderately worse just for a couple of days. So you know what, that's actually pretty common for people to have fluctuations like that. Let's just try the next dose. I try really hard to convince them to try the next dose using other rationales, not breaking the code and telling them it was a placebo, because then if they go, oh, okay, yeah, I'll trust your judgment on that, and we proceed on and nothing different happens, great, and we're going to get success or failure ultimately, but at least we will have tried. But if they really push, like, okay, no other possible cause of this, they're like, all right, well, what you need to know was that was a placebo dose. And the reason I did that was because I need to be clear as to whether the dose you're taking truly caused this change or whether it was a placebo effect, which is very common. I have not met very many people who are willing to admit or believe they could have a placebo effect, and that's kind of baked into the cake. That's just sort of the nature of the beast with our mentality and our psychology. But it's very common. It's at least 1 out of 5 people has some kind of placebo response to things. And you normalize it, right? Like, you're not weird. It's not all in your head. I'm like, this doesn't mean that your symptoms are a product of your mental state or your psychology. Your symptoms are probably real, but you can absolutely amplify them with your level of stress response or fear and anxiety. Or what I usually tell people is, like, if you're walking around outside on a bright sunny day, you know the sun is there, you can feel the heat, but you don't look right at it, right? You're just living with it and you're like, yep, I feel it. And people go about their day with their chronic symptoms in the same manner. Like, you have to kind of ignore your symptoms to a point in order to live your life and have a functional existence. And then you take an LDI dose and the practitioner says, I need you to pay really close attention to this symptom for the next week. And it's like looking directly at the sun. Now it hurts, it's burning a hole in your retina, but it's the same sun it always was. So what's different is your level of vigilance and attention to your symptom, and that gives you the perception that it's worse. And that is extremely common, and it doesn't mean anything about your brain or being wrong or whatever. It's just the way people interpret things differently with a different focus of their attention. And that has been very well received by patients. And I think I talk about that part in the placebo video for patients, and like, oh, okay, yeah, I get it. We don't get very many patients anymore that are upset about the placebo thing. Like Jeanette mentioned, it's in our intake form, and it's very clear that it could happen, because we say, is Dr. Vincent allowed to use placebos if he sees fit? And there's a yes answer, and there's not a no answer. Because if they say no, it used to be like, say no, I'd be like, well, I don't want to work with you. You know, and occasionally now people are like, what is the placebo thing? I don't want to use placebos. And it's like, okay, well then good luck, find a different practitioner. And they're like, what, why? I'm like, because this is such an important tool in figuring some people out, that you need to know that it might happen so that you have basically implied consent, and we need to be able to do this if it's necessary to actually help you. That's the thing I had to learn to explain to people. I am doing this to try to help you to solve your problem, and unfortunately this is one of the tools that we know we have to use in medical science. And I pursue medicine as a science as much as possible, which is a challenge because of all the variables that you cannot control, and human psychology that you cannot control and can be hard to read. So, there's a video about it. Have the patients watch the YouTube videos that we have before they start if they want to. Read the patient handout. I can't remember explicitly right now if I have a placebo discussion in the patient LDI handout. I hope I do, because it would make sense to put it in there, but I can't with positivity say that it's in there. So anyway, it's a really big deal. You'll find it very useful. It'll help you sort out confusing situations and actually get to a point where you can help the person, and that's what it's all about. So common examples of chronic illnesses with microbial immune reactions, you got Lyme disease, like I mentioned earlier. Even in the acute setting, somebody has a tick bite and they get the rash, the fever, the adenopathy, the joint pain, whatever. Even the day that starts, you can treat it with LDI. You may feel uncomfortable with that and want to give them antimicrobials first. And for some portion of the population, if you put them on like doxycycline for a month, they'll be okay, right? That's the conventional medical view. It must work some of the time. But this is an option. It's a little more nerve-wracking to try to treat someone who has acute, really bad symptoms. That makes us uncomfortable. It makes them uncomfortable. So it won't surprise me at all if people are uncomfortable starting with that. Totally fine. They'll wait until the patient kind of settles into more of a smoldering, lower grade and lower intensity chronic illness picture, and then they feel comfortable trying it. Cool. But I can tell you from my limited experience with just a couple of cases over the last 10 years that you can treat the acute setting too. Acne. What's that? You could do both, and like I mentioned yesterday, I will get patients who are on antibiotics or herbal antimicrobials or whatever for their Lyme, and they think, you know what, it's really helped me like 50%, 60%. It's enough that I can live my life and function, and I don't want to stop the antibiotics. And I'm like, okay, cool, then you can keep taking them. What I discovered is if we titrate through with the doses and we get complete resolution of their symptoms, and now it's a dual therapy resolution, the LDI dose plus antibiotics, if you then they get to the comfort where they can, okay, I feel like I can stop my antibiotics now, in a significant number of those cases, it's going to change their LDI dose that they need. And because withdrawing the antibiotics allows the antigen to rise in presence, it usually moves the LDI dose in the weaker direction. So if you give them, like, if you got to a 10C Lyme dose and that was where they resolved, and then they stop their antibiotics, you give them a 10C Lyme dose again, they may actually flare up for several days to a week. And then their knee-jerk reaction was to go right back on the antibiotics. Oh, I need the antibiotics. And after I went through that with some people, I'm like, you know what? Here's what we'll do. And I would tell them, like, some people, this shift occurs in their LDI threshold. And so what we're going to do is we find the dose that works. You let me know, like, you've stopped your antibiotics. The next dose we give you, I'm going to back it up from 10C to 12C. Usually going back 2C is plenty. And then they're like, oh, okay. And maybe the 12C doesn't do anything. And then you go 11.5, 11, and you go, oh, like 11C is what works for you now. Great. But they only had to deal with their symptoms for a couple of weeks, and they could endure that. And now you have them on a single therapy that works without any collateral damage. And so there's a way to do that, transition that way. But I had...
just meant for an acute tick bite, like you could just use Lyme C and pneumonic,
Oh, at the same time?
Yeah.
I don't understand the logic behind using both at the same time. If, you could, of course you could. But then what are you going to do? You're going to stick with two therapies, maybe, and feel uncomfortable stopping one.
On it for 4 weeks, right?
Yeah, maybe on for 4 weeks, then they stop.
No, then you stop, and then you see.
And so if you do it that way and you do initiate antibiotics and LDI at the same time, I would still follow that same guideline of backing up the LDI dose. And so that's fine. You want to start them together, like, hey, this is working, and I know removing one of these may cause a shift, so I'm going to preemptively lower this dose so that I don't overdose you. And you just tell them, like, it may take a couple of weeks to fiddle with it and get it back to where it works, but let's just make sure that works so you don't have to be on antibiotics forever. And that's well received by people now.
Because I'm just thinking those cases where they do the 4 weeks and then a month later their symptoms come back. And
Yeah.
you're like,
Right. I know we should all have a certain reluctance, like a bad taste in our mouth, putting people on antibiotics for a long period of time. It just seemed like the only route, the only avenue we had for people for a long time. And I get that. And then when I started talking about this, I'm like, there's another way. There's something else you can try. But how do you make the transition? How do you square the circle of two very, very opposing theories?
I find it's a psychological thing. You reinforce the idea that it's an infection to the patient, and once they're like put them on antibiotics and you go out, then they're like convinced
That's true.
They can't let that go and even try to switch them alive. So it's kind of open that door and it's hard to close it.
Yeah, that's a really good point. Dr. Abraham mentioned you're dealing again with patient psychology and what I would call patient belief systems, right? Our beliefs become our reality even if they are wrong. And that's a difficulty. So what you'll notice, like he was saying, is once you put them on antibiotics and they have a response, their belief becomes that it's an infectious process and they need antibiotics to be well. That becomes their belief system, and it's difficult to unlearn that or to reprogram that. And so even when you give the person an LDI dose and they get the rest of the way better, a lot of these people will be reluctant to stop the antibiotics. And it took me a while to devise a strategy of discussion and explanation and modification of my approach for patients to overcome that. But like I was saying, you go, okay, you can stay on them together, you can treat this as an infection, we get the immune response under control, and when you're feeling well and you're comfortable, let's try to transition to a monotherapy approach that doesn't have risks, right? And people are usually cool with that. Like, hey, you're doing great, let's just stop the antibiotics. And the next time we give you an LDI dose, we'll back up a little bit. I'll send you the titrations between 12C and 10C, and we'll find where you do well with LDI alone. And and they're like, okay, cool, yeah, because who wants to stay on antibiotics forever? It's just a lot of decisions people make are based on fear and anxiety. And fear is a terrible way to make decisions, but it has kept us alive this long. So it is a very difficult thing to deprogram from people to make decisions based on fear. You need a lot of logic and reason and scientific validation to get somebody to choose differently than what their fear told them to do. And that's just people, most people. Then you get the occasional weird person who's like, sure, yeah, whatever, which, like me. That makes sense, let's try it. But as long as it doesn't seem super risky, and we all have our own risk aversion threshold. Other things that I like to re-mention: cold sores, genital herpes, shingles, postherpetic neuralgia. These are some of the most fun things to treat. Those of us who have used this therapy with success, especially something like postherpetic neuralgia, shingles, it's miserable. These people are in horrific pain all the time, unrelenting. They're taking amitriptyline, they're taking gabapentin, they're taking opiates, and they're still like, this is miserable. And if you can fix that for them, you've made a friend for life. and with no drugs, and you're like, wow, this went away. I remember the first time I tried it, I've just, I'm creative, I guess, and I'm willing to try things that more than other people, apparently. So I'm like, well, this should work. Like, why does this one person still have chronic nerve pain 10 years after they had shingles and other people don't get that? And you think about it that way, what is the difference? What is the difference, the defining characteristic between this person and this person? They have one thing in common, the varicella virus. What's the difference? And in a lot of those cases, it's the immune response. You will find that out as you start to play with this new toy. Merry Christmas, you get a new toy. But you do have to buy it yourself. So there's that. But you'll just be like blown away by the results you can get with some of these things. It seems like magic, and that's what I tell my patients. I'm like, this sounds like bullshit, but when it works, it seems like magic. And my mother even used to tell people that I gave them a potion. It was like the word she would use. Well, I told them you give them their potion. I'm like, I didn't go to Hogwarts. I went to the University of Washington. Okay? This is not a potion. This is a homeopathic dilution of an antigen. And to stop saying the word potion. I know I'm picky about words, but come on. That's really different. And so the PANDAS group, PANDAS is easy if that's truly the case, because they'll respond to strep 9 times out of 10. PANS is a wastebasket of neurodevelopmental chaos and inflammation, and those parents are the most distressed, anxious parents you'll meet. And on that note, I will talk about something for a minute that will be very controversial with the people involved, not necessarily the practitioners. Many of you this will resonate with you. But I will say that anxiety is contagious. And anxiety from a mother to a child is not just contagious, but there is a direct line. It is like hardwired. It's not even Wi-Fi. It is hardwired. If the mother is afraid and fearful and anxious, she will make the child sick. Absolutely. Because I find some of the most important places for me to use placebo doses are in young children. The mother is so intensely afraid, and you can get that, you can smell it, you can taste it when you talk to them. They're just so just so terrified about their child's illness and the chance that it would make them worse. And if they know that the LDI dose could potentially make them worse, and they may tell you a story like, we tried this, everything made him worse, and I'm so worried everything's going to make him worse, I give them placebo doses to start with. And in that particular circumstance scenario, very, very often the child will get sicker. And it's a kid who has no idea. It might be a 6-month-old or a 5-year-old. They've got no idea. They don't even know what they're doing. The mom's just squirting stuff under their tongue. So it's not a placebo response of the child. It's just not. It is a placebo response of the mother, and that direct lines to the child. And I've seen it so many times, I am convinced this is a reality. But if you try to explain this to the mother, you will get zero agreement on this. Because how could a mother be willing to believe that they made their child ill? No one wants to think that way. There is so much cognitive dissonance. There is so much resistance to that. They will not. In some cases they will, and I love it. The mothers that are willing to take a breath and go, you know what? You're probably right. It's like, I'm like, how about you go on vacation? And dad gives them the dose. Maybe we do that, and it would work a hell of a lot better actually in these particular instances. But this is such a reality, and the way I make sense of it is that, I have a lot of metaphysical beliefs and feelings now after years of dealing with psychedelic therapy and different things. The way I view things, the universe, living systems is very different than it used to be. Quantum entanglement, like we know if two particles are related to one another, even if you send them to opposite sides of the universe, when you manipulate one, the other one automatically manipulates reciprocally and in turn. And the quantum physics scientists have shown this, and they're like, this is weird, it makes no sense. Think about a mother and a child. That is your flesh. All of your mitochondria, or all of the child's mitochondria, are mom's mitochondria, not dad's. Okay? Which I totally understand why the kids always want to cuddle with mommy and not me. I get it. It took me a while to get over that, but I totally get it because I have this new belief pattern that makes it okay. Like, they'll come around eventually when they learn to drive. That'll be my deal. Because moms do usually not like teaching their kids to drive. It's terrifying. And it's just part of that whole picture, right? The mom's in the room like, yeah, you're right. It scares the shit out of me. So, dads have a layer of separation from this, and sometimes the dad is like, we can, let's just relax, and the mom is like, ah, and the child is totally responding to the mother's anxiety and fear. So if you can get past that, and the placebo thing sometimes helps, but I've run into this a number of times and had no way of resolving it. It is a difficult problem. I think doing some kind of psychedelic therapy with the mother is probably what might help, honestly, the most, but that's going to be a big challenge. So you'll run into that, and the PANS kids are where I see this the most. I don't know what it is about a kid or pandas too. I don't know what it is about a child with tics, not TICK, the blood-sucking arthropods, but like, twitches, eyelid, eye blinking or throat clearing. These are not life-threatening symptoms, right? These, on a grand scale of things, these are just quirks. These are kind of weird, annoying symptoms. Parents are more distressed by a kid's tics than by their rash or by their bloody diarrhea or by like whatever. It's so interesting to me, and I think it's because mothers are much more sensitive to the necessity of having a good social network, right? Males have a tendency to be fine being in isolation, being solo. Women have this, I need a community, and everybody needs to be supportive of my kid. And it's very true. In society, your child will be much more successful if other people like them. For sure. Which is, I don't know how I made it this far, because I don't think too many other people liked me as a kid. I'm pretty sure they didn't. But, you get through it, and the moms will be really tied to that. But this tic thing, they will be so distressed by it. And Jeanette and I have noticed over this, like, what is the deal? Why is that weird? And I'm like, because everybody looks at their kid. Like, everybody's like, what's wrong with your kid? And that's just like, oh my God, I cannot contend with that. And it's an interesting thing. But if like the child has a visible ailment, a rash or asthma or coughing, everybody has sympathy for you. Like, oh no, your kid's got this illness, but if your kid's just ticking and twitching, like, what's wrong with your kid, right? It's a perception of the symptom that's different. I think that's the case, but you'll run into this with these neurodevelopmental things where people have a really hard time with it. And on the neurodevelopmental side of things, this is a low success rate with LDI, unfortunately. Pandas is an exception. Strep works great, but if it's the pan situation where it's not strep associated and it's just this basket of variable symptoms and chaos with some similarities, there are too many potential causes for that situation. All the chemical toxins that interfered with brain development in that child, multiple allergies, maybe immune reactions, maybe they have a methylation defect, maybe they have mycotoxins that are part of their picture. There's so many things that add up into that constellation of dysfunction that LDI alone has a very low success rate in that population. But it is worth a try. When I try with these people, I generally take the ones that have demonstrated success, which are like Lyme, strep, yeast, foods, maybe chemicals, but some of them, and I have a list in our provider manual of these like neurological things. It's on there. Here's the things to consider trying. Ask some questions to decide what order you may want to try them in, but try them all and try them in combination and try them relatively quickly, because I will go through all the options I have with these people. It'll probably take 6 months, even at the pace that I like to set for this. And the vast majority of them don't respond. 75%, 80% easily, it's not going to work. And then you got to decide what else you want to try. I would, again, I mentioned it I think earlier in the weekend, I would suggest people consider psilocybin in this population, because I see that the part of their brain that is not working like it's supposed to is that last evolutionary step of humanity, where we learn to cooperate with one another, we learn to communicate with one another, we learn to read each other's emotions and social cues, and we learn to be a society. And these kids have trouble with all of those things, and psilocybin has demonstrated success in developing neuron growth and interconnectedness in the prefrontal cortex. And I've been implementing this with some kids, and I have seen response. It's early. I know they're starting to do some studies, not in the United States so much, where we don't necessarily favor non-drug related therapies, of course, for obvious reasons, but in other countries, Europe and things like that, where they're starting to study this in autism spectrum kids, and the PANS kids will fall into that bucket to some extent. And I am really excited to see what they can turn up and what they can objectively document. Every time I see studies using psychedelic substances, things, they always, in my opinion, underdose people. So I'm hoping, same thing with vitamin D, they always underdose vitamin D and go, oh, we get these results, but they're not that impressive. I'm like, give them 5 times more and you'll see. So take it with a grain of salt. Like, here's the study, I'll look at it like, oh, they're giving people 10 milligrams of psilocybin and they should be given 25 or whatever. That number is based on synthetically made psilocybin, where it's the chemical itself, not whole mushroom extracts, where you might want to give like 100 milligrams of a whole mushroom extract to get 10 milligrams of psilocybin. Anyway, think about it, go down that road. I think the more of us explore that, we will quicker find that it's successful, and we can help so many more of these kids. Psoriasis is a cool one I've talked about, where in many cases it's a fungal reaction on the skin, so the SFF can work. But I've seen the skin bacteria work in a few cases. I've seen foods work in some cases. I've seen strep work in some cases. For guttate psoriasis in particular, those of you who don't know that term, guttate means droplets. Remember the old apothecary measurements that was GTTs, like for eye drops or ears? GTT is guts, like, which is droplet, okay, in like Latin. So guttate psoriasis looks like you took a handful of liquid psoriasis and splattered it on the person. That's what it looks like. Little pink dots that have a little bit of scaling. It usually involves the face and head in my experience, but then the trunk and other places. That responds to strep in every case. It's one of those occasional monolithic situations where, the diagnosis automatically leads you to the antigen choice. Sarcoid is one of those. Guttate psoriasis is one of those. There aren't very many. Inflammatory bowel diseases, you'll see, that is another complex bag of problems for people. And they might have various toxin reactions in the gut, maybe mycotoxins they go through. So even something like mycotoxin mixture might be part of the solution for an inflammatory bowel case. The parasites, the foods, even gluten, mycobacteria or the GI mixture, yeast for sure. Yeast and the GI mixture or mycobacteria are usually the ones I think of first for most IBD cases. But just there's a list. And so if you look in the formulas list, you'll see inflammatory bowel listed under a lot of these. And if you look in the practitioner manual, is where it's disease-based. You go to like bowel disorders, you'll see this menu of possibilities, and you'll be like, okay, I'll work through that in some order. But again, if they say, I was put on antibiotics, like they thought I had SIBO, and they put me on neomycin or Xifaxan, and my symptoms got tremendously better while I was on it, but they only gave me a 2-week course, then my insurance wouldn't pay for it anymore or whatever, and it all came back like, oh, well, let's start with bacteria. You know, because you killed bacteria, you got better, let's try bacterial antigens, the GI mixture, for example. But if they say that made no difference, and then somebody gave me fluconazole, and oh, that worked great while I was on it, then try yeast. You know, these are clues. They're not absolutes, but at least it'll help you rank order the antigens in which order you want to try them, and probably have success sooner than you otherwise would have. That's the best you're going to get. What do I got left? Matching disorders with the antigens. There's rarely a one-to-one relationship, except for some of those examples I mentioned. Be creative, think broadly, try different antigens. Certain antigens can cause lots of different conditions, like strep. You can get rheumatic fever, gottate psoriasis, post-streptococcal glomerulonephritis, which is a mouthful to say. You could have loss of taste and smell after COVID that's strep-related. OCD, pandas, those are strep-related. And these are different systems, right? And what was the other one? Something else we talked about this weekend? Tourette syndrome, some cases. Again, brain inflammation as a categorical situation, right? So just you'll learn about these things as you go. You'll get really good at a handful of things that you see commonly, and then you'll see weird, uncommon stuff now and then, and you'll go back to the manual, back to the formulas list, and go, oh, what about this? And you, if you really dive into this therapy, a couple of things will happen. One, you'll be really impressed with the things you can treat with this, and it'll make you kind of excited about it. And two, people are going to come to see you from all over the place, because you're able to treat conditions that did not have a successful treatment before. And that's one of the features that made me feel kind of liberated to experiment and play with it. I'm like, well, nobody else can fix this, so what the hell? I'm going to give it a try. Whereas a good contrary example would be venom allergy. So like people who have life-threatening reactions to bee venom, fire ant venom, things like that. There is a tried and true venom desensitization protocol that the conventional allergy world has set up that's kind of a progressive desensitization strategy like OIT or SLIT that we know works. And these are life-threatening situations in many cases. So I don't screw with it. Like people go, well, could you treat my bee sting allergy with this? I'm like, possibly, but I'm not going to. Like, why? Well, because you'd have to take a dose and then get stung by a bee a week later just to see if it worked. Oh, yeah. Like bees aren't always accessible. They're seasonal in a lot of places, not here. But that's really risky. And so I'm just not going to do that, right? So I don't advise anyone to do that either. But it's one of those applications where theoretically this would work. But in practical terms, it's potential, professional suicide to do that. So I don't recommend that. Drug allergy is another one. Somebody has a severe drug allergy. Could you take that drug and dilute it, like with aspirin or whatnot, or penicillin or something, and find a point that works? Probably. But in order to find out, they have to willingly test themselves with something they know is dangerous a week after every dose. Maybe if they have a skin reaction, that's safe enough to do it, go for it. But if it means swallowing a dose of penicillin and breaking out in hives or having to do an EpiPen, there's just not a lot of buy-in. And there's almost always an alternative drug you could use for the situation. So those are a couple of conditions people have frequently asked me about over the years that I just have resistance to. I'm like, for practical purposes, I don't think it's worth exploring that part of the wilderness. But could it work? Sure. Theoretically, it very well might. Using antigen combinations, like you talked about, this is something I started to do really in the last 3 or 4 years, maybe a few years. I was like, I'm trying all these things one by one for people. It's tedious, it's time consuming, it's cumbersome, it's more expensive. Why don't I just take certain things and group them together? So we have the Lyme yeast parasites, the LYP mixture, which for all of your kind of complex, chronic, I'm tired, I can't think straight, I have unexplained pain and neurological symptoms people, I almost always start them with the LYP because it's faster than doing Lyme and then doing parasites and doing yeast. Each one takes a few months. It's just, let's take 3 months and rule them all out if that's the way it works. If you really want to know which one of them is working, you can figure that out easily too. Just use the LYP, and let's say you get to like 9C and their symptoms all go away. Great. When their symptoms come back, give them Lyme 9C, give them yeast 9C, give them parasites 9C till you figure out which one of them is working, and then you can just ditch the other two and give them the one that they need. The antigens are so cheap though that I haven't had anyone do that. They're like, whatever, yeah, cool, doesn't matter. I mean, if you think about it monetarily, I think I spent about $5,000 buying the original lime mixture because the guy I was getting them from would put things together for me at a very low cost. There are 75 organisms in there though, and if you tried to buy them now from suppliers that sell them individually, each one is about $500. So you're gonna spend like $40,000 just to make your own lime mixture. And then you're gonna need to raise your rates and recoup the overhead cost. But for me, it was really cheap considering I got 30 milliliters of the lime mixture. And if the average, even if the average treatment dose was 3C, that's 30 million cc's. You know, it's just billions of doses for all these people. We have enough of this mixture to collectively treat everyone on the planet with Lyme disease for the next 100 years, no problem. And I don't think we even have 100 years left, so we're good. Smoke them if you got them. And so hormones is another one. I have like testosterone, progesterone, estrogen, insulin, thyroid, cortisol, DHEA, and then I was like, why don't we just put them together? Because hormone sensitivity is not very common, and having more than one hormone sensitivity would be even less common. So it's faster to just use them in combination. The herpes, the same thing, the GI, the HGM, big broad mixtures gets you to the destination faster. The Farm B is just the acronym. I could have called it BARF-M or something, or RAMFUB or whatever, but I just thought this made a word more or less. FRAMB might have been better sense, but it's Francisella, which causes tularemia, right? Francisella tularensis, the American disease. You skin a rabbit in the wild, you get this bacteria, you get tularemia. Anaplasma is in there because when I first made the lime mixture, I did not know anaplasma existed. And so I didn't want to remake the whole lime mix and go, hey, it's lime 2.0. I actually have a lime, my current lime we used to call lime 3.0 because I had already changed it a couple times. So this would have made a lime 4.0. And I already had 100 doctors using it. So I didn't want to remake it. So anaplasma we have available as an individual antigen if you want to try it. And people will report the same kinds of syndromes and symptoms with anaplasma that they will with Lyme disease. So it's in that same vein. I have not yet, when I was using it individually or as part of the Farm Bee, I have actually not seen anyone respond to anaplasma. But if you do, let me know. The R is rickettsia, so that's like Rocky Mountain spotted fever, scrub typhus, recurring fever, or whatever from rickettsial organisms. M is mycoplasma, but it's actually mycoplasma and chlamydia. So I just thought there were already enough letters in here. So our mycoplasma mixture is mycoplasma species and chlamydia combined, because I see them as similar intracellular organisms that do not have a cell wall. And they, we know that chlamydia can be associated with certain autoimmune syndromes, namely Reiter's syndrome, if you remember that one, conjunctivitis, urethritis, and arthritis, I think, spondyloarthropathy, seronegative arthritis. And then B is brucellosis or brucella, slaughterhouse fever, that thing. So I just thought of these one day. I was like, what are some other things that cause weird illnesses in people that are random, and I put them together. The Farm Bee mixture I have used in a lot of my people that have failed with the other things. I haven't seen any of those work in anybody yet. So if you try it and it works, please let me know what that situation looked like so I have an understanding of where it might be applicable. And then the herpes mixture is varicella, herpes simplex 1 and 2, HHV6, and EBV and CMV. I think those are the ones. It's in the listing, but I used to have them all individually. I'm like, well, we'll try this one, this one, this one. I'm like, this is really slow and expensive, so I just put them together for you. And I'll probably come up with other combinations as we go, based on my logic and reasoning and what I think makes sense. So we email people out updates, new things, new ideas as they come, and you can be part of that whole collective. If you're maintained in our network, you'll get the information, you'll have access to the antigens. We are, this year, sometime we're going to have a provider certification that's available to you, which I mentioned earlier, which is not going to protect you medical legally. So you don't go into court and go, well, I was certified by Dr. Vincent in this therapy, so you can all go hail. It's not going to protect you. It's an experimental therapy, but what it will do is let the patients out there who are aware of the therapy know who has had some accountability in terms of verifying their training. And so attending one of our workshops like this since 2020, so some of you are out there are people out there who maybe did workshops with me in 2018, 17, I have really changed things a lot since then. So I was just like, at least since 2020, please. If you have some kind of credentials that verify that you have had broad clinical training, physician's assistant, nurse practitioner, naturopath, DO, MD automatically qualify for credentials. If you're a chiropractor, if you're a veterinarian, if you're an acupuncturist, if you're a certified nutritionist in America, but you were a medical doctor in Russia, you have the skill and the training in the background, and you can appeal to me, write me an email, a letter, whatever, and say, here's my training, here's what I've done in practice for this many years, and here's my understanding of all this stuff. I'll be like, cool, you qualify, because I don't want it to be limited in some narrow-minded way to somebody's professional licensure. To me, it's more about, can you do this effectively? And like Jeanette, Jeanette can treat most things just fine. She has an MBA. She doesn't have a medical degree, but she's been living with me, for better or for worse, for over 9 years, and she understands this stuff a lot. So I wouldn't say that she can't do it because she didn't go to medical school, right? This is a unique sort of thing. So it's more like a vocational training. It's a different skill set. This last slide, and then we're also going to require that you go through the practitioner manual. It's going to be presented through our website in such a way, or not the website, we're going to send it to you as a link after you have bought into the provider network. So you got to be in the provider network, have done a training course, go through the manual, and it will have quizzes after each section that will be interactive. We have to update it a little bit and make sure everything's correct. I went through the quiz questions, and I need to modify a couple of things in the manual so that the quiz questions and the manual information match up before we release this. And of course, it's electronic, so it's a mess, but we'll get it out to people and let you know. And then the other element of being on the practitioner certification list is you're going to have to make a video at home of how you make dilutions and send it to us so we can watch. If you want to do it with a costume on or a cool background or make it fun for us, by all means, go ahead. Tell us you're diluting toenails or something. I don't care what you're diluting. But we just want to make sure that we know you can make the dilutions correctly. It's just one bit of accountability that we think is important. And so that's the other piece of it. And it's not a lot, but it's several things. And you do that, and then it's not an extra charge. We're not going to charge for the certification, like you got to pay for that. It's just you can be listed on our website as active practitioners who have met these criteria. And so patients will know where you are, and they'll know what state you're in, and it'll help them find you, because patients ask us all the time. And I'm like, I can't just validate that everyone's good at this therapy, because a lot of them, I just don't know how they use it. They don't communicate with me. They don't ask me questions. So I don't have a working understanding of their level of skill. And this will give us a way to feel comfortable recommending some of you as practitioners to the patients out there. And I think there's value in that for everybody involved. Let's see. So Jeanette answered the antigen question that's in the chat. You can all read. General categories of illness. This is kind of what's in the last part of the practitioner manual. It's like GI issues, think about these things. Skin issues, think about these things. Respiratory, think about these things. And it's kind of a nice, breakdown in a kind of a broad strokes manner to give you a starting point, at least, of what antigens you might try for what problems people present with. And so it's a good place to start. And then, again, the formulas, mixtures, you go through that a number of times, and you'll start to become familiar with what antigens affect what conditions. And then you'll just go forth and have a blast with this, most likely. I mean, I'm pretty confident that if you start playing with this and using it, it's quickly going to become one of the more common tools you use. 5 minutes? Yeah. We have 5-6 minutes left. I'm done. If anybody has, if anybody has any kind of last questions, please throw them at me now. Otherwise, we may just quit 5 minutes early, which is great. Here in Hawaii, the word for done is POW, not P-O-W, which also is a way to be done. But POW is P-A-U. And there's a common thing we say in Hawaii, pauhana. Hana means work. And so pauhana means work is done, and it's playtime. And that was never more true than today. So we're going to have a wonderful day. It's beautiful and sunny here on the Big Island of Hawaii, and it's only noon. Some of you are in time zones where it's like 6 p.m. and it's getting dark. Enjoy your Sunday. Have a good week. feel free to ask me questions about things as time goes by. I'll answer you. I may answer you in a very brief, succinct Asperger's kind of manner. Don't take it personally. It's just the way I communicate. And I got to answer 25, 30 emails a day, and I'm not inclined to include all of the niceties and the warm fuzzies that people in society are accustomed to, but you will get a very clear and cogent answer. and that's really what I think is expected of me. The last question there is, what is HGM? It's in the video from yesterday, and it's in, I think, the formulas list, what that is, but it's human gut microbiome. It's a really interesting one to talk about because this is made up of about 90 different people's autologous samples, oral swabs and stool samples, because I was like, I use the GI mixture, which is very limited, parasites very limited. There are so many organisms living in the human microbiome in the gut. I thought if I got 90 to 100 people's samples, I might get 99% of the microflora of the human GI tract represented in there, and maybe that would work for a whole host of things that my other antigens haven't worked for yet. So far, I have not been impressed that it works for very many things. It's usually like chronic gut symptoms is where I'll tend to use it, or even people who have arthritis or other kind of extra gastrointestinal symptoms that don't respond to other antigens. I'm like, maybe it's a gut organism and they're reacting to that. So here's my way of kind of shotgunning or shitgunning, this at people and seeing if they respond to something in there. And I've had a couple of cases who have responded seemingly effectively and clearly. So it's one of the things that's worth trying. I don't lead with it though. It's not what I would start with. It's been a great event so far. Oh, thank you guys. So have fun with it. Ask questions, talk to colleagues. If you find out new information, please, please, please share it with me. I've always said that since I've started teaching and preaching this for years, and very few people do it. So just, anything, new information, new experience, hand it to me. What's
They're
that?
on our Facebook page.
What's that?
I said,
Oh,
you guys can continue to email me and our Facebook page, which Ty is now participating in, which is really awesome.
not quickly. She has to tell me that somebody put a question on there, and then I'll go and answer it.
It's progress. So, but we're getting a little baby steps. So we will get back to you as soon as we can with answers.
Anyway, thank you all for your attention, and thank you all in advance for forwarding this therapy, this new mechanism of health and healing for people. And I know all of you will thoroughly enjoy using this in your practice if you embrace it and you go out and you give it a shot. So, everybody have a wonderful rest of your day and week. Signing off.
And recording.